is the only, please mark my words, it is the only prospective randomized controlled clinical trial that has established mortality benefit for a treatment modality in COVID-19. The only non-controversial mortality benefit that has been established in COVID-19 is using steroids. What was used in recovery? In recovery, dexamethasone orally if the patient can swallow, not as a parenteral injection. What is the dosage? 6 milligrams. What is the frequency? Once a day. What is the duration? Up to 10 days. This is the low dose dexamethasone. My colleagues and earlier experienced clinicians who used to treat TB meningitis would remember dexamethasone being given for weeks and weeks and weeks. We never got mucormycosis in such TB patients. Okay, in the context of the present rage of mucormycosis and the black, the white, the yellow, the color-coded fungus pandemic which we are seeing in India particularly, there is a need to use steroids only when they are indicated, only in the dosage prescribed, and only for the duration. Yes, what do the guidelines say? For moderately severe disease, the Government of India Clinical Management Protocol says dexamethasone 0.1 to 0.2 mg per kg for a duration of 5 to 10 days, or IV methylprednisolone 0.5 to 1 mg per kg for the same duration. In severe disease, the dosage is double, but the duration is 5 to 10 days. We are every day seeing patients getting steroids for 2 weeks, 3 weeks, 4 weeks even in high doses. If you see the dose of IV methylprednisolone, the dose is 0.5 to 1 mg per kg per day. So if the person is weighing 50 kg for moderate disease, one would give 1 mg per kg would be 50 mg. So please remember this, use steroids when required, only when required, in the dosage prescribed for the duration. There is a background to why I am emphasizing this. It will be evident in the next few slides. A word about anticoagulation. Anticoagulation prophylaxis is indicated in patients with moderate disease, and the therapeutic dosage is indicated in persons with severe COVID disease. Please watch for the other predisposing conditions that result in the development of DVT. Also keep that in mind, and the anticoagulation should be given accordingly. The anticoagulation indicated is unfractionated heparin or low molecular weight heparin as per the guideline. The role of new oral
Mohan, the slides are
anticoagulants,
not moving. Yeah.
up to which now it is okay.
Yes, yes.
There is some issue with the CLRI, and I do not know, sir. Zoom is our teaching protocol program in platform for last 1.5 years. Okay, see, this is the high dose. This is the protocol for the anticoagulation. Role of newer anticoagulants, they are not listed in the guideline, so I'm not talking about them today. The one word about the principles of management of COVID-19 and post-COVID-19 mucormycosis. Here I want to add, my center, the Sri Venkateswara Institute of Medical Sciences, has been designated as a state COVID hospital in April 2020. Until today, we have treated more than 10,000 moderately severe and severe critical COVID in this institute. We have used corticosteroids when indicated as per guideline. We have used the low dose dexamethasone as per recovery protocol. Today, I have 100 mucormycosis admitted in my hospital. None of these are the patients treated in our institute. We have treated 10,000 patients. We have used corticosteroids. Our patients did not get mucormycosis. Is this the only underlying factor? We manage diabetes. We monitor diabetes. we try to keep the control as appropriate as possible when we use the steroids particularly, and we use the low dose dexamethasone as the primary modality of corticosteroid treatment. So now, in the given limited time to me, what I can say is medical management of amphotericin, medical management of mucormycosis is LAM, which is the liposomal amphotericin B. There are other poorer alternatives like posaconazole or isavuconazole. Adjunctive therapies have been reported in some studies, but they are not, their benefit is not proven. And of course, timely, judicious surgery. So this is the nutshell summary I wanted to communicate. To give a quick take-home message, the key issue in the management as per the new guidelines in the management of COVID-19 is clinically assess properly respiratory rate and the arterial oxygen saturation as measured by pulse oximetry, stratify the disease severity, asymptomatic, mild, moderately severe. Depending upon disease severity, the patient is either managed at home or at a COVID care center, or the patient is admitted to a hospital in a ward or in an intensive care unit. The laboratory testing, the imaging modalities are driven by the disease severity stratification. This is how the resources are optimized. From mildly severe disease onwards, oxygen therapy is indicated for everyone, and for the individuals with moderately severe disease or above, anti-inflammatory and immunomodulatory therapies are indicated, and anticoagulation is also indicated. This is the basic issue I wanted to share with you, and I thank you all for your patient hearing. In spite of the glitches, I think probably I may have taken 5 or 10, 6, 7 minutes more, not more than that. I rest my case. Thank you. I sincerely thank Dr. Krishna Prashanti, our Vice Chairman of the APAPI, and also one of the leaders in academics in the IMA, for giving me this opportunity to be with you here today. And I rest my case.
Thank you, sir. That was a wonderful talk that you have given, the newer guidelines. Let us unlearn what we have learned from the experience of treating the first wave, and let us be ready for the third wave by judiciously using the anti-inflammatory drugs and anticoagulants so that we can prevent this burden of mucormycosis as Dr. Aladi Mohan has given to us. Now just let us quickly go to the questions that are answered. One question that is being repeatedly asked is, what is the importance and how the testing of saliva can be used for testing this COVID-19 infection? This is for Dr. D.S. Murthy, sir, if you can answer.
Yes, madam. Actually, I typed in the chat box as well. The presence of the virus in the saliva is not standardized, and the test kits we are using are not standardized for saliva, though they are standardized for other specimens. So you may use it saliva for research purpose or for some comparative studies, but for diagnosis per se, it is not a dependable specimen. Though the as the one of the chat box, it is mentioned that it reduces the exposure, but whatever the case may be, it is not a good specimen for taking the diagnosis.
Sir, I have a question, sir. Everyone is now using this rapid antigen test, and that is not being reported to the government, and so we are not getting the statistics. So how can we link up to the government reporting?
But actually, that is the problem, madam. Rapid antigen test per se is good for tracing and tracking the patients at the early stage. But the problem is that people who are doing the rapid antigen test are not registering with the government. So actually, as a mandate, because all these are the notifiable diseases as per the government rule. So all these labs or hospitals which are doing RAT have to register with ICMR as well as the state government. Then only they are authorized to do these tests officially. Then only we get the clear statistics. So actually the issue of RAT is the wider availability, but the problem is the misuse of these tests. It is a good alternative to RT-PCR test, but I advocate both tests having similar sensitivity and specificity. Both can be used depending upon the availability. RAT only facilitates early diagnosis because of its wider availability.
Okay, sir. Thank you so much, sir, for answering. Now that we are losing time,
Yes,
I
ma'am.
close this session. I request the attendees, the delegates, to post privately their questions to the faculty. Thank you very much, Dr. Krishna Prasanthi and Dr. Ivani, for giving me this opportunity to moderate the first session. I also thank Dr. Subramaniam, sir, for making me be here. Thank you, sir. Thank you.
Madam, am I permitted to go for my rounds?
Sir, okay, sir, but will you join again? Some people may be having some questions.
Yeah, I need to sort out a few issues today.
Huh.
I'll be back.
Okay, sir. Thank you so much, sir. Thank you.
Thank you,
Over
sir.
to
Alladi
Dr.
Mohan, sir.
Krishna Prasanthi.
1 minute, sir. I'll reserve all the questions for you. Kindly join at the end of the session, sir. Total CME at your convenient time. Thank you, sir.
ఒక్క నిమిషం నేను చేస్తాను.
Thank you, Alladi Mohan, sir. This is Dr. Vani.
So kind of you, madam, for bearing with me.
Thank you, sir.
Can we move to the next session?
Yeah, sure, Funny.
Good morning, all of you. Good morning, our national president, our state president, and the branch president, and all the dignitaries, senior and junior members, and my dear friends. We are into the next session. I welcome our distinguished speaker, Dr. Vani. Dr. Ivani is a professor and head of the Department of Obstetrics and Gynecology in the Government Medical College, Srikakulam. And she is a member, State Expert Committee for COVID. And she is the Honorary Secretary, IMA, AMS, Andhra Pradesh State. Now I welcome her to deliver her experiences, both in the first wave and the second wave. And she is a good teacher and a very sincere, committed COVID care specialist. Thank you, Dr. Vani. Please start your lecture.
Thank you, Maninder, for the kind introduction. So let me share my screen. So is my screen visible?
Yes, very much.
So hope I'm audible clearly and my screen visible.
Yes, madam. Yes.
Yeah. So thank you very much for the kind introduction. And good morning, all the participants. So very happy that 1300 already have registered for this program, and I can see on the platform around 500 plus participants. So thank you very much for all who have registered and all who are listening to this webinar. So my topic is also a very contemporary one. So a lot of challenges the obstetricians are facing during this COVID-19 pandemic. So therefore, the ICMR, the Ministry of Health and Family Welfare together, they have given certain good clinical practice and regulations. And these guidelines are widely used by all the obstetricians throughout the country in delivering the maternity health services. I would like to start the presentation with some important statements the Ministry of Health and Family Welfare has given. COVID-19 presents an immediate and emergency challenge to the obstetric practice. However, it should be ensured that we provide safe maternal services to the women, and they should never be impaired during this COVID pandemic. And under no circumstances, there should be denial of essential obstetric services to the pregnant women, and no case should be denied irrespective of the COVID status. So because their COVID status was not checked, we should not deny the services to a pregnant woman. So these are the dictums which were given by the Ministry of Health and Family Welfare way back 1 year ago. So these are all the essential services related to OBG. Antenatal, internatal, postnatal, the management of sick newborn, immunization, family planning, abortion services, and also adolescent health. So my talk would be limited to the antenatal, intranatal, and postnatal care and the guidelines laid for this category of women. As in the earlier presentation, Dr. Murthy was saying whom to test. All pregnant women who are in the need of admission are tested irrespective of whether they're symptomatic or not. So they fall under category 5 of the ICMR testing guidelines. So any pregnant woman with symptoms, or even though they're asymptomatic and close to term, those who are in labor, and all neonates are being tested for their COVID status. And ideally, we perform the RT-PCR test. Unless it's an emergency, we go for the rapid antigen testing. All the labor room units are provided with the rapid antigen testing kits, which we do it on an emergency basis. But if they are negative, we usually confirm again with the RT-PCR test. So this is a strategy which is followed throughout the country. So my presentation would go in these outlines. What is the effect of COVID-19 infection on the mother? What is the effect of the infection on the fetus? What antenatal care to be given in the non-COVID pregnant woman? So because that is also an important concern. And what antenatal care should be given to a confirmed COVID-19 infected pregnant woman? Pregnancy and childbirth, they generally do not increase the risk of acquiring the COVID infection, but if they are infected, clinical course is likely to be more worse than the non-pregnant counterparts. However, in our experience, we saw that more than 90% of infected pregnant women, they recovered very well and they are asymptomatic or only mildly symptomatic. But pregnancies with comorbidities like hypertension, diabetes, heart disease, or renal disease, they fare bad during pregnancy, and the maternal mortality is higher in this set of pregnant women. Then coming to the second part, what is the effect of COVID-19 infection on the fetus? So this is most worried part from the mother's side. So here I can confidently say that the extent of vertical transmission of the infection from mother to fetus is still unclear, but our experience says it is not happening. The vertical transmission is not happening. But in a setting where in the third trimester, if the mother is COVID positive, within 14 days of her expected date of delivery, so then there is a chance of some congenital infection, probably to the extent of 2% is possible. The third part is how to deal with about the antenatal care in non-COVID pregnant women. So because we cannot postpone or we cannot ask the women to stay back at home during pregnancy, but still we follow the strategy that we reduce or postpone the antenatal visits and to reduce the duration of the visit and limit the attendance. So these are the policies we are doing in the routine antenatal clinic dealing with non-COVID pregnant women. Then coming to the most important part, what antenatal care and treatment is required for pregnant women infected with COVID-19 infection. So one important aspect which differs from the non-pregnant counterparts is the severity of the disease, and is there any difference in assessing the disease severity in pregnant women? So according to the latest guidelines, the categorization of mild, moderate, and severe disease is an objective definition. Objective definition in the form of respiratory rate and the SpO2. So these two things will decide whether the woman is having a mild disease, moderate disease, or a severe disease. If you go into the severe disease category, the respiratory rate and SpO2 less than 90 will make it as a severe disease. But look into the small difference in the pregnant women, that SpO2 less than 94% itself, we should categorize as a severe one in pregnancy. Why? Because remaining complacent is more dangerous than being more cautious. So for this purpose, we take 94% SpO2 as a severe form of disease in pregnancy. So this is the only difference between the non-pregnant and the pregnant. Then if a pregnant woman is found to be COVID positive, if she is asymptomatic or she has only mild symptoms with SpO2 more than 95, then the issue is very simple. If she is not having any comorbidities or obstetric emergency is not there, then we generally ask her to be under home isolation with fetal monitoring after 2 weeks after the disease or the positivity status. So when after 2 weeks she comes back, if she was a case of first trimester, then we do a detailed mid-trimester anatomy of the fetus through a detailed ultrasound examination. And if she is infected in the second or early third trimester, we consider sonography for the assessment of fetal growth. So that is the only thing we do if she was in the first or the second trimester and a mild or a asymptomatic disease. Then there are certain danger signs during home isolation which should be clearly explaining to the pregnant woman. The symptoms and signs of the warning ones are similar to that of the rest of the adults, but here we should understand that mild breathlessness or myalgias, fatigue, these three are common even in a non-COVID pregnant woman. So therefore, the assessment of the symptomatology regarding the warning features, we should be even more meticulous in deciding if the symptom is a danger one or a non-dangerous one. Then coming to the patients who are categorized as moderate and severe disease, these should be hospitalized. In a dedicated COVID hospital, these should be hospitalized, and they all need a strict monitoring of vital signs, right from temperature, heart rate, respiratory rate, blood pressure, and SpO2 measurement every 2 to 4 hours if it is a severe case, and every 4 to 8 hours in a moderate case. Then when to investigate? A mild disease or asymptomatic disease only because she is COVID positive need not have any other additional investigations for COVID status. But if in case it's a moderate or a severe disease, apart from the complete blood count, absolute lymphocyte count, NLR ratio, kidney function test, liver function test, apart from these, we also require certain investigation to decide the prognosis in the form of C-reactive protein, ESR, IL-6, LDH, ferritin levels, D-dimer levels, and these should be also repeated every second or third day depending on the case severity. But one point regarding the D-dimer interpretation. So normally above 500 in a non-pregnant adult is taken as an abnormal value, but in pregnancy we should understand right from the first trimester an elevated D-dimer is a physiological point in the pregnancy. So therefore, in the third trimester, values of around 3000 plus of D-dimer is still considered to be a normal value rather than an abnormal value, and this should not alter the decision of the thromboprophylaxis or the other treatment decisions. So this is an important difference between the pregnant and the non-pregnant. Then regarding the drug treatment in case of a pregnant, positive, moderate and a severe disease, we know that oxygen therapy is the key role, steroids, antibiotics, whether yes or no, anticoagulations, antivirals, and tocilizumab. So we look into each of these. So regarding how much oxygen has to be given has to be decided by multidisciplinary team, which includes the physician and the anesthetist. Regarding the steroid, the only point I would like to make here is that methylprednisolone, which is generally given as a steroid of choice in the COVID management, here we should understand methylprednisolone doesn't cross the placenta. And we are looking into the fact that the fetal lung maturity also has to be improved by given steroids. We prefer to use dexamethasone rather than methylprednisolone. And then in certain cases, we can go with dexamethasone for 2 days initially, later by methylprednisolone. That is another good option. So this is the point of difference between the administration of steroids in a non-pregnant and a pregnant woman. Then coming to the anticoagulation, we know that pregnancy is an additional risk factor for thrombosis. So therefore, all pregnant women should have a risk assessment for venous thromboembolism, and anticoagulation is generally indicated for all in-hospital management of COVID-19 pregnant women, irrespective of the D-dimer values, because the interpretation of D-dimer is very difficult in pregnant women. And regarding the use of remdesivir and tocilizumab, remdesivir should be considered only in patients with moderate and severe disease requiring supplemental oxygen within 10 days of symptoms onset and with no renal or hepatic dysfunction. The dose is similar to the non-pregnant, and no known fetal toxicity was associated with various studies done with injection remdesivir given in pregnant women. So therefore, it can be given if she meets the criteria for a compassionate use. This is regarding remdesivir. Regarding tocilizumab, there's no enough data worldwide to say that whether it can be given in pregnancy or not. So generally it is avoided. And ivermectin, doxycycline, these two are category D drugs, should be surely be avoided in pregnancy because the benefit is also not established even in a non-pregnant adult. Monoclonal antibodies, which is coming up nowadays, should be avoided in pregnancy. Then the other important dilemma with which all the obstetricians are facing every day is whether refractory severe COVID disease has to be delivered or we should be going into wait and watch policy. So this is the very common dilemma, especially if the pregnancy is 32 weeks and beyond. So delivery may be considered if it is allowing further optimization of the recovery. So mechanical ventilation alone should not be the criteria for delivery, but so many other aspects we have to take into account. Then regarding the intrapartum dilemmas, what is the preferred mode? Should a birth companion be allowed along with the women? Can antenatal steroids be given? So when to start the medical management? Should it be planned or cesarean section has to be postponed 10 to 14 days until the COVID negative status? So these are the common dilemmas which we face during the delivery. So mode of delivery, whether vaginal or C-section, unless is obstetrically indicated, we go for a vaginal delivery. So there is no study which said that vaginal or C-section, which is preferred over the other. So therefore, we take the obstetric indication as the benchmark to decide whether a woman should have a vaginal delivery or a C-section. The second, should it be planned induction or a cesarean delivery should be planned? So there's nothing like a planned delivery. So all these indications, whether planned or on an emergency basis, should be decided on the obstetric indication, not because of the COVID status. And as I've already said, glucocorticoids for fetal lung maturity for all admitted cases in the 3rd trimester, we generally administer glucocorticosteroids, and dexamethasone should be the steroid of choice. Then regarding the postpartum issues, we have, I've mentioned here 4 important postpartum dilemmas. Should COVID positive babies be separated from the mothers? Should COVID positive mothers breastfeed her baby? Or any specific COVID related adoptions? Can the mother be vaccinated in the postnatal period? So these are the common dilemmas which obstetricians regularly face. The first one, should COVID positive mothers and babies be roomed in or separated? There's no recommendation of separating the babies from the mother unless the mother is sick and in the ICU. So there's no protocol or recommendation to say that the mother and baby should be separated. But what is more important is that breastfeeding should be established as per the normal protocol, and then the mother will wear a mask and then she breastfeeds her baby. Okay, the mother wears a surgical mask and performs the breastfeeding, and then only a transient isolation of the baby is recommended. Then during the postnatal period, infection control measures, strict monitoring in the next 48 hours, giving analgesics, giving all the thromboprophylaxis if needed, all should be done as per the routine recommendations. But here a word of caution regarding the puerperal fever. If a woman is having fever in the next 48 hours to 1 week post-delivery or post-cesarean section, this has to be evaluated whether it is due to the delivery process or if it is due to the COVID status. So this point has to be borne in mind. And the other thing is, which we have observed, that postnatal depression is very, very common in the COVID positive women. So therefore, assessment of the postnatal mental status is also a key factor in the postpartum monitoring. And when should the mother be discharged? For asymptomatic patients, 24-48 hours after a vaginal delivery or 3 to 4 days after a cesarean section is the ideal period for the mother to get discharged if she is an asymptomatic one. And regarding the mild, moderate or severe, it is a multi-team decision which will decide so when the mother recovers and when she should be discharged. And on the discharge, a thorough counseling is very, very important. The thorough counseling, like, so how she should observe the COVID appropriate behavior at home, and how she has to see the danger signs in the postnatal period, and regarding the breastfeeding, isolation, everything should be told at length at the discharge. And for how long the mother and baby should take the precautions while at home in the postnatal period. If she's an asymptomatic mother, 10 days after the testing, and if she's a symptomatic mother, at least 10 days after the last symptom has passed away, or at least 3 days without use of antipyretics, or when the symptoms have totally resolved. So that is the period when she can be safe, and then she can go about away from the isolation protocol. So probably this is my last slide regarding the postpartum dilemmas. And then I would end my presentation with a request to all the participants, all IMA members with specialty diploma or degrees or super specialty degrees, please join IMA AMS group. With a life membership, you can contact me on my phone number or Dr. Krishna Prasanthi. I'm the secretary of IMA AMS and Krishna Prasanthi is the chairperson. You can contact any one of us, and we humbly request all of you to join IMA AMS with a life membership. So thank you very much for your very patient listening. So thank you all.
Thank you, Dr. Vani, for your very lucid presentation. And you have clearly explained about the categorization and looking into the oxygen saturation, unlike the general public. In pregnant women, you said that less than 95 is one should be very careful and to be considered as a severe category. This is a highlighting clinical issue because, you know, categorization at that moment is very important. Then you have also mentioned about the warning signs and symptoms, and you have given the importance of D-dimer levels, which need to be considered and which need not to be. And then your other clinical approach, like mother and child transmission also? Because the data shows elsewhere that there can be a chance, but your experience shows that there is no transmission at all. It's a wonderful finding. And the cesarean section only when there is an obstetric indication. And thank you for the analysis also on the safe breastfeeding. And thank you very much for your very clear and elaborate explanations. Thank you very much. Now, can I invite the next speaker?
Yeah, sure.
Yeah. I invite the next speaker, Dr. Achyut, who is a dynamic, a young critical care specialist, who is an alumni of Andhra Medical College and has done his MD anesthesia from Rangaraya Medical College. He is presently the head of the team of the critical care at Apollo Hospitals. He is currently the secretary of the ISCCM, International Society of Critical Care Medicine, and Visakhapatnam chapter. He is also a DNB teacher and also examiner. Now I request Dr. Achyut to deliver his lecture on oxygen, modes of oxygen administration. Thank you, Dr. Achyut.
Good morning. Good morning, and Dr. Faninder, sir, for the nice introduction. And I thank all the IMA dignitaries for giving me this opportunity to be here on this platform. And it's a great opportunity for me to come in front of you today and share my experiences with the management of COVID. And the topic given to me is rational utilization of oxygen in COVID-19 situations. I hope my video is clear and
yes.
I'm audible.
Yes.
Thank you. So rational utilization of oxygen in COVID-19, we had multiple situations in our country where there were mild to severe panic situations, and there were multiple reported and unreported episodes or events of deaths or near deaths in many hospitals across the country. And this open report, open data tracker, I don't know how far this is close to the real picture. They reported about 512 deaths related to oxygen availability in this second wave of COVID so far. And you can see multiple news articles. We don't know whether they were exaggerated or underplayed. We are not very sure, but we have to assume that what we are seeing is just the tip of an iceberg. And the other facet of this problem is the medical oxygen requirement has gone up by at least 7 times. And some companies said they met 60% of their demand, that inox air. So we have to really accept the fact that we had episodes and we are having episodes of oxygen unavailability across the state and across the country. And thanks to the intervention of the state and central governments of our country, that there was prompt response from the government authorities, and they tried to mobilize oxygen from resource areas to depleted areas by train. So then comes the government orders and instructions for rational usage of oxygen at hospitals. And as I said, that was a prompt response from the government, though it was the degree of the pandemic was not anticipated as much as this is happening now, and preparedness was not adequate looking at the numbers, but definitely the response was well appreciated, and they mobilized the resources and instructed the various hospitals and clinical teams on appropriate usage of oxygen in hospitals. So what does it mean? Rational usage of oxygen or rational usage of any drug for that matter. So according to WHO, appropriate to the clinical needs. It does that meet the individual requirements in doses that meet the individual requirements, an adequate period of time at the lowest cost to the patient and to the community. This is for antiretroviral therapy, which was mentioned in one of the WHO websites, and the same applies to oxygen as well. So what are the government directives? Various state governments under the direction of the central government came out with a clear and detailed instruction to the district administrations and various hospital administrations. So they came out with a target SpO2 of 90 to 94 if there is no increased work of breathing, and monitoring the oxygen saturations continuously in the ICUs and very frequently on the wards for all the hospitalized patients, and then use appropriate equipment like nasal cannula with a flow rate of 1 to 6 liters per minute and face mask of 5 to 8 liters per minute, and restricting the usage of HFNC high flow nasal cannula using high flows of oxygen when it is not necessary or other options are available, and using non-rebreathing mask with good fitting one, and using CPAP machines or BiPAP machines at lower oxygen flows. And these CPAP and BiPAP machines, they use lesser oxygen flows compared to the HFNCs. And all these, even they went on to further about inflation of the cuff pressures of the endotracheal tubes, so that the leak in the system, the breathing circuit, is less. And going on to the standby modes on the ventilators, and both invasive and non-invasive, when the oxygen is not in use or the ventilation is not in use. So this tells us how detailed they looked at with minimal oxygen wastage, because every ml of oxygen matters, and it is life-saving medication. And we have seen the importance of oxygen in this pandemic. When we have it, we don't realize the importance of it. When in a IP patient, we used to struggle discharging patients who do not need oxygen or hospitalized care because of their fear that they may deteriorate and may not get a bed to if at all they need to come back. While those outside the hospital, we used to see them dying outside the hospital because they couldn't get a bed in any hospitals. So that's how we understand that it's a life-saving medication. So what is the physiological basis for these numbers, 90 to 92% or 94%? And why should we aim for this range and not less or not higher than that? Let's look at the oxygen cascade and oxygen dissociation curve and understand these numbers. And in this picture, you can see various three limbs going in and out of the alveolus. So the inspired air from the top, that is oxygen, inspired oxygen, it contains around 21 kilopascals, because it is 21% of oxygen in the atmospheric air. And obviously there won't be any carbon dioxide except for the pollutant. And the venous fraction, that is PVO2, coming into the alveolus, that contains 6 kilopascals of the oxygen, and the carbon dioxide is 7 kilopascals. And once it is oxygenated adequately, the pulmonary venule carries oxygenated blood at an oxygen pressure, partial pressure of 13 kilopascals and CO2 of 5 kilopascals. For conversion, we need to, if some of us are more familiar with millimeters of mercury, and for conversions, we need to multiply these numbers with 7.6 so that we get the millimeters of mercury values. So this is how the physiology of alveolus and gas exchange is aimed at. And this is called oxygen cascade. On here, where my arrow is, you can see that the oxygen in the various parts of the this cycle from atmospheric air to the mitochondria in mitochondria in the cytoplasm. there is gradual fall from 150 millimeters of mercury or 21 kilopascals of partial pressure of oxygen in the atmosphere, that comes gradually to about 15. And then in the arterial pressure, as we looked, it comes to 100 millimeters of 100 millimeters of mercury here. And then there is a big drop, sorry. And then there is a big drop in the oxygen partial pressure between the arterial blood and the mean capillary blood. And the mean capillary blood, it is about 50 millimeters of mercury. And this is where the guidelines say that we should aim for around 60 millimeters of mercury in the arterial gas. And that 60 millimeters of mercury corresponds to 60 millimeters of mercury. You look at the red arrow on the screen, and the x-axis, 60 millimeters corresponds to 90% saturation on the y-axis. And this is where we aim for. And we don't want it to go further down, because the partial pressure will be less than the capillary blood, and then there won't be any additional transfer of oxygen from the arterial blood into the capillaries. This is the physiology, and this is what we have to understand. And many of the ICUs now are managed by doctors of various specialties, and we usually are used to see oxygen saturations close to 100. And now and the panic starts if the oxygen sats start going down below 98, 97, 96. And if at all it is a stable value around that region, we don't need to worry, unless there is something sudden is happening and the oxygen is dropping rapidly from 100 till 80. And if we are catching that in that downward slope, then we need to panic. But if the patient is stable with SATs of 92 to 94, we don't need to panic as we used to be. And this is the physiological basis for that number. And here there are studies to support this 92 to 96 ideal target, and even 91 as we looked at oxygen dissociation curve and the oxygen cascade. So the ideal would be above 90 and below 96. And there are studies to say that the mortality is increasing if it is less than 90. That is LOCO-2 trial. And then IOTA trial, supplemental oxygen with SATs targeting more than 96 are not useful in any positive outcome in the general population. And there is slight variation for the pregnant women and the children, as you can see on the slide. So here, what supplement, you can see the list of oxygen supplementation devices: low flow nasal oxygen cannula, which is used 1 to 6 liters per minute, and then standard face mask or MC mask, as Dr. Alladi Mohan was saying, 5 to 10 liters, partial rebreather mask more than 10 liters, and sorry, non-rebreather mask with more than 10 liters. And see, look at the reservoir volume also. There is physiological reservoir in our pharynx and nasal cavity, which amounts to about 100 to 150 ml. And on the top of that, these additional devices on the face would provide reservoir volume. And the air entrainment mask, they can give about 100 to 200 ml. Non-rebreather mask with a reservoir attached to the mask, it gives 600 to 1000 ml of reservoir. And high flow nasal oxygen, though it won't add reservoir because the flow as such is high, it doesn't need to have any reservoir. But we need to understand that the oxygen delivered is dependent on the oxygen delivery device that we are using. And this calculating oxygen requirement, you can see the same nasal prongs, Venturi mask, face mask, non-rebreather mask, non-invasive ventilation, invasive ventilation. This is useful to calculate the oxygen demand in your hospital. So this is a nice table given in the AP government's directive for estimation of the oxygen demand, so that we can prevent oxygen accidents due to unavailability of oxygen. And we don't have all the time in the world to get the oxygen from the point of manufacturing to the point of delivery. We need to have adequate reserves. And it is suggested that every healthcare system has at least 1 day's consumption as reserve, and necessary measures are to be taken to ensure that such a reserve is there, such a store is there, and the life is protected from losing due to lack of oxygen. And this is how we have to calculate based on the oxygen supplementation device, and then flow rate going on, and then the number of patients in the hospital, and what is the usual oxygen required for day is all depicted in this table here. And oxygen therapy, there are standard guidelines to follow oxygen, when to start and when not to start. And if you look at this flow chart, if the patient is in on the top left corner, you can see that patient in respiratory distress. If the patient is in impending arrest, intubate or put him on a reservoir mask. And then if the patient is not in respiratory compromise or not in respiratory peri-arrest state, then you start supplementing oxygen with a target of 94 to 98. This was in before our COVID situation. This was what we all were used to, and now our target has come down to 92 plus or minus 2. So if the patient is not maintaining saturations less than 92, then we go for oxygen supplementation. And at the same time, we have to monitor the patient saturations frequently. And if the patient is on ICU, and monitor the oxygen saturation continuously, and then titrate the oxygen flows according to the saturations, and keeping the target around 92. And also you can see this flow chart is very useful. You have pH, PCO2 on the chart, and then you decide whether the patient needs NIV or invasive ventilation or simple face mask or nasal cannula. And then this is again another slide showing the Venturi masks which are color coded, and what percentage of oxygen that you will be able to deliver to your patient. So blue Venturi that gives 24%, white 28%, yellow this is 35%. This is standard color coding. And then there are signs of respiratory deterioration, like increase in respiratory rate if it is more than 30, and drop in oxygen sats, and increasing oxygen requirement, and CO2 retention, drowsiness, headache, flushed face, and tremor. These are all signs of respiratory deterioration, and we have to act accordingly and go for the appropriate oxygen delivery device. And how do you wean oxygen flow to your patient? As you can see, if the saturation is less than 90%, we don't need to continue. More than 90%, we don't need to continue oxygen. And here, this flow chart suggests that we decrease the oxygen flows by 0.5 liters, but we can't be that accurate with the flow meters of 15 liters flow. So we usually go by 2 liters decrements or increments time to time. And once, if it is less than 6 liters, we go for face mask to nasal cannula. And this is how we have to wean the oxygen supplementation to our patients. So reducing oxygen wastage. Yes, we know that about 30% of oxygen is wasted at various levels of the supply chain, from the oxygen manufacturing unit onto the tanker, and then from the liquid oxygen tanker into the liquid oxygen storage cylinder within the hospital premises. From there, the supply chain, the tubing at various levels, there will be leaks. And the major contributor to the wastage is at the patient end. That is, two things: when the patients are maintaining good saturations, then also we end up giving higher flows, because either because of there is lesser level of monitoring, patients maintain 100% sats and he's getting 10 liters or more, which the appropriate step would have been like reducing the oxygen flows and maintain the oxygen sats more than 92, around 94. And also when the patients are moved to a different area for some investigations, the flow charts are flow meters are still there to the patient unit, and then constantly oxygen is lost, and that goes unnoticed for a long time, and we lose significant oxygen. So by all these ports of spillage, we lose about 30% of oxygen, and then and this has caught attention, especially when there is severe shortage of oxygen. And you can see in the slides here that oxygen nurses, initially this oxygen nurse, we have never used this word oxygen nurse, and various governments suggested oxygen nurses to monitor the oxygen usage and then limit the wastage and make the hospital prepared for the supply of oxygen and having adequate oxygen stores. So these were the duties or job description for the oxygen nurse. So the bottom line is don't waste oxygen. Reduce the oxygen flows titrated to the saturations targeted, and go for equipment which require lesser flows of oxygen. Choose NIV over non-invasive ventilation over high flow nasal oxygen if you have enough of ventilators, and close all the oxygen flow meters which are not in use, and check with the maintenance department and make sure that all the regulators are monitored and controlled, and estimate the oxygen requirement, ongoing oxygen requirement, and warn them in advance to procure adequate stores, and check the OT stores and look at the fallback options so that no healthcare setting lands in a situation where people are going into respiratory distress and death situations because of lack of oxygen. So even our state government came out with these detailed suggestions, and this was around 4th of April, I think. So our government came out with this, sorry, 26th of April, came out with these guidelines, which gives detailed information about the target of oxygen sats, administration of oxygen, and then measurement of oxygen demand, and then maintenance of stores. So that was nice from the government side. And there was, so yes, we are seeing patients with who are dying or going into respiratory distress because of lack of oxygen. And at the same time, if you don't control oxygen, there is other facet of this problem, that is oxygen toxicity. So oxygen, when it is given in adequate doses, it is good. And it, like any other drug, if it is too much of anything, is not good. And you can see here in this slide that oxygen, excess of oxygen would result in increased oxygen free radicals, that is superoxide or hydrogen peroxide or hydroxyl radicals and ions, which are capable of damaging the vital components of the cells. So we should not give too much of that either. So what happens in the lungs and what happens in the rest of the body, most of us know. The lungs, if they're exposed for a prolonged period for high concentration oxygen, that would result in ARDS-like picture in the X-rays and CTs. And we know the retinal membrane formation in neonates. And other tissues other than lungs and eyes, also there is possible damage if we give too much of oxygen to our patients. So we need to cut down on oxygen supply to the patient, titrated to the oxygen saturations. And finally, to summarize, what do we have to do? Do not administer too much of it. Make sure that your patient is safe and SATs are more than 90, and the target is maintained between 90 to 94. And don't waste oxygen. Make sure that there are not many leaks or no leaks at all, and make sure that there is enough of oxygen in store. Assess your patients frequently and estimate your oxygen demand regularly, and make sure that you have fallback option. Thank you, and I welcome any discussion. Over to Dr. Faninder, sir.
Thank you, Dr. Faninder. Thank you, Dr. Achyut. You have explained very simply, though the complicated topic it is. And your routine work is with such oxygen management, and you have emphasized on how to avoid the wastage of oxygen.
Yes.
And what is the required range of oxygen you have mentioned in between 90 and 96, and less than 96, what are the benefits? And we have explained thoroughly the physiology behind that. And you have thoroughly explained also the flow chart in oxygen therapy. Thank you very much for your excellent presentation. We will, I think, Madam, the chairperson, can we go to the next speaker?
Sir.
And we will answer the questions at the end of the session, Dr. Achyut.
Yeah, sure, sir.
That is our plan. That is our plan. That's
sure.
Okay. Now I will be able to invite our next speaker, Dr. Madhusudana Rao, who is a senior ENT surgeon who has done his MS General Surgery from the prestigious Postgraduate Institute of Chandigarh. And he is a senior consultant ENT surgeon, and he has a hospital. It is the Madhumani Nursing Home at Nandyal. So he is a past president AP ENT Surgeons Association, and he is an expert in the cochlear implant. And he is running a 50-bedded NABH accredited ENT hospital. And he does basal surgery, skull surgeries, FESS, snoring surgeries, and micro ear surgeries. And I invite him to share his experiences regarding the mucormycosis. Good morning, sir. Over to Dr. Madhus. Hello, sir.
Are you able to hear me, sir?
Now you are able to hear. We are able to hear.
Sir, I'll share the screen, my PowerPoint presentation.
Yes, sir. Please, sir.
Okay. Are you able to see the
yes, sir. We are able to see the slides.
I'll go to the slideshow.
Yes, sir.
Mucormycosis. The topic given to me, it's 12 o'clock. As time is running, I'll keep up to your expectations. The black fungus. I first thank the IMA AMS webinar organizing people and Krishna Prashanti, Vani, who are in regular touch. Nowadays, no patting, no shake hands, it's only big namaste. And I'll keep up to your expectations, sir. This is my 50-bedded Madhumani Nursing Home Hospital. It's a tertiary referral hospital in southern Andhra Pradesh. From nose, the black fungus is going everywhere into the skull. As COVID also enters the nose, as mucormycosis. What is the root cause? The root cause for all these crises, now the pandemic of Corona is there, 2 waves, and in that now a new spectrum has come into the field. All the patients of mucormycosis are post-COVID, received high steroids, sometimes I can say indiscriminately, landed in non-diabetics into diabetics and diabetics into poor control. These have made his immune system cut down to the lowest level. Now the opportunistic mucor has taken the advantage of a low immunity of a human body status and start eating away. The incidence, prevalence, recurrence, mortality, all are a big question mark, because this is now seen only now in 1 month or maximum about 2 months, not seen in first wave, only in second wave, because this steroid induced less immunity. Even a busy ENT surgeon who is having 50 to 100 OPD cases per day hardly sees 5 cases in a year. But now I myself seeing 2 to 3 cases per day. That means you can imagine the incidence and prevalence and epidemiology itself a topic. Just as a glance, I am telling the severity of post-COVID diabetics, low immunity is alarming on rise. What is the symptomatology, sir? That is the main thing many people will be asking. I'll just brief. Sir, the earliest symptom is excessive crusting and dryness in the nose. And after that, they start experiencing paresthesia, mainly over the maxillary or V2, trigeminal second division of the cheek. Then comes the nasal block, sometimes serosanguinous discharge. Then starts visual disturbances, drooping of eyelids, ophthalmoplegia, not able to move the eyeball, double vision, and all these things. And the most important, this unbearable headache. Patient comes, sir, I am relieved of COVID, got admitted, they have treated very well, I am now well, but my head is paining, unbearable headache. This can present even as a second symptom. Once this not treated at this stage, they go into intracranial spread. In that intracranial spread, the boundaries have crossed. It's just like a wildfire, and patient is succumbed to death, sir. And some patients, not all, they complaining of upper alveolar because the maxillary sinus hosts its floor, the maxillary tooth. So these may combine. What are the clinical signs? The symptomatology, patient comes to you in front of you in an ENT surgeon or a neurosurgeon or a dentist. These three people are now dealing with mucormycosis. When you see the nose with an endoscope, you see a blackening of mucous membrane. You all know our oral cavity and nasal mucous membrane is pinkish in color or rose in color. It becomes dark in color, sometimes black in color, necrotic slough, and you ask the patient, he will not be able to have a good movement and drooping of upper eyelid. First thing happens is drooping of upper levator papilla, diminished sensation of V2, facial swelling. And I'm just showing some of my patients who I am seeing within these 2 weeks. They present like this. And this is a patient where the left-sided ophthalmoplegia, proptosis, eat away, hard palate, blackening, and severe pain, tooth, everything. And this is the presentation. And if you put an endoscope, see the turbinate, darkish in color, losing its vitality, even the hard palate, alveolar, and classical ophthalmoplegia, ptosis of the eyeball, and they present like this. And all these patients, standard complaint is unbearable headache after COVID. And you see, they don't know that they are not being advised at the time of discharge, please control your blood sugars. You are okay, I am okay. Oxygen is good, no breathlessness, go back. And 300, 400 blood sugar levels. They don't now concentrate. This is a classical middle turbinate, necrosed dark picture you see on an endoscope, you just put in the OPD. Now, what investigations? I cannot go into the detail of investigations, but I can say the best is gadolinium enhanced contrast T2 weighted fat suppressed MRI. Why? Because eyeball contains a lot of fat. Your mucormycosis, black fungus invading the orbit, gives the same signal as the fat. So what you have to do in gadolinium scan, you suppress the fat so that only the pathology will be enhanced. CT scan for bony boundaries, what happens to the bony boundaries, you can see in CT scan. And sir, the simplest, easiest getting report within 2 hours is potassium hydroxide KOH smear. Take a secretion from the nasal cavity or a small piece of tissue, send it in normal saline, not in formalin, send to your nearest laboratory, KOH mount. They say that there are growth of fungal mycelia, then biopsy and culture. Classical black fungus will look on a slide. I am presenting my personal experience in Nandyal town in Kurnool district, sir. All these are my personal cases. I have not taken any from the book. And you can see the black fungus grown in the culture and the test tube. And these are the petri dishes. Coming to the treatment aspect, because the COVID mucormycosis has, it's a burst out volcano now. I can say COVID itself is a big volcano, and this is another volcano which is danger, and I am going to discuss about what are the factors. Treatment, sir. There are only two things. Earliest, as fast as possible, surgical intervention. Next is antifungals. And this is my surgical team, Madhusudan Rao, and assisted by Dr. C. Manideep. I have not mentioned Dr. Rohit, and anesthesia by Dr. G. Ravi Krishna, who is an active member in IMA, AP State, and he gives a wonderful hypotensive and anesthesia. This is my theater setup. The huge armamentarium is necessary to do black fungus, and this is how you have to record, see what is happening, and multiple procedures are there. They are all target oriented, custom made to that particular patient, depending upon the MRI, CT, and other features, comorbidities. Modified Denker's maxillectomy, extended maxillectomy, total functional endoscopic sinus surgery, necessary orbital decompression or orbital exenteration, total maxillectomy, infratemporal and pterygopalatine or retromaxillary extensions can be endoscopically managed. Sometimes alveolus has to be, all teeth to be removed, and any tissues mutilation. What I would like to stress upon, all are elite in this webinar, the huge costly infrastructure is necessary to deal with mucormycosis. This is OrthoCare Cobblator, which is ionic dissector. It controls the bleed and removes the tissue. And you need a powerful micro drills and a good pottery and Storz Image 1 HD cameras for the clarity, or you can do with any camera, and skull-based drills and various micro blades, drillings, diamond drill, cutting burrs, micro debrider, angled blades, 45 degrees, 120 degrees, because the opening of nose is 1 centimeter. But you have to go through that 1 centimeter passage and go anywhere, as my first shown. You can go into the orbit, you can go into the sphenoid, base of skull, everywhere, sir. And you need a good amount of endoscopes, all varieties of endoscopes, all are Storz, because you cannot use for the next patient, and you need angled endoscopes. And because I cannot show the video clip, I'll stop share and go to the video clip and show how a small clip I'll show, sir. Now I'll again share my video. Are you getting the video, madam? This is the endoscopic picture you are seeing, and the blackness, devitalized, not going.
We are
and
not
all-
getting the video, sir.
Sir,
Okay.
video, we are not
on the
able to see
video,
the
sir.
video, sir.
You
Yeah,
click
okay.
on the video.
Sir, I think that was the problem I was facing. I have to share it, and again, I'll just come to the.
Just click on the video, sir. You'll get it. On in
I'm-
your computer.
I'm just clicking on the computer, madam. Are you getting the video? No. I'm playing the video. Are you getting, madam? No.
Sir, I
No,
think
we
you
are
can
not
minimize
getting,
this. You can minimize this sheet. We can see the video.
I
image,
think
sir.
I will first minimize the screen and
Yeah, yes.
show,
Yes.
because
Minimize the PPT, sir.
I think that is, I had to minimize the PPT. I'm sorry, madam. I have minimized the PPT, and now, are you getting now the video?
No, sir.
PPT is not yet minimized, sir.
PPT.
It is
I
occupying
have-
the screen. Yeah, it is occupying the screen.
PPT I have minimized. Okay, your screen is fast.
You,
Somewhere some.
you click,
Are you able to get the video? No.
click,
No, sir.
click.
Stop share. Okay, madam, I'll do one thing. If necessary, I'll go to the last and show you the videos. Now, let me continue the PowerPoint. Are you now seeing the PowerPoint now?
Oh, yes, sir.
Okay, I'll just go to the.
Sir, please go to slideshow. Yes, yes, sir. It's coming
Now
up.
we
Are
are
you
able
able
to
to
see.
see the slideshow, madam?
Yes.
Okay. What is happening is, actually the slideshow has an hyperlink. I don't know whether, are you getting the video now? No.
No, sir.
No, sir. No.
No, okay, sorry. I think I'll do one thing. I'll not disturb your video, our lecture. Okay, right. Are you getting the slide there now? Are you seeing
Yes.
my slide? Okay, right. See, this is the endoscopic 70 degrees view of the left side maxillary sinus. This lower arrow is the maxillary sinus. This is the orbit, madam. And I have shifted with a retractor the globe of the left eyeball, and you can see the black fungus invading from the floor through the lamina papyracea, going all around the eyeball. So slowly we have to go along that plane and this thing. And this patient whom I have shown has lost his vision. So we are only cosmetically preserving the eyeball and not. If the eyeball is also invaded with the fungus, we have to excentrate. There is no other way. This is not my picture. This is one of the picture how mutilating will be a mucormycosis invading the facial tissues. If the skin becomes dark like this, what you are seeing on the face, the same thing happens all around. Just at 360 degrees, it will be going on eating away. And these patients, if they survive, you have to reconstruct with the myocutaneous flaps and all these things. This is, I have borrowed from Sunshine Hospital in Hyderabad. And what I would like to stress upon is, more than COVID, the post-COVID mucormycosis is more lethal, and death rate is almost 50 to 60% if you do not involve much earlier. Now, what is my topic is emerging crisis. See, I'm having
Sir.
35, I passed away my MS in 1986 from PGI Chandigarh. 35 years of my experience, I would have not seen even 35 cases. But now, we are seeing so much. So, what is necessity? The crisis is now like oxygen. Hardly one cylinder may be necessary for a 5-bedded hospital. Now every hospital needs hundreds of oxygen cylinders. Like that same lack of skilled ENT surgeons. Now comes lack of antifungals. I'll tell the topic. Poor diabetic control. So you need a huge amount of diabetes. And how to few years we have to face this. This is not going to end the chapter, madam. Like COVID, second wave may end now, but this new car people will come to hospitals. So, and most important is costly equipment. If you need a good IPC micro debrider, it is costing more than 20 lakhs. If you need an endoscope, whatever it may be. Sir, anything,
sir? Sir, there is constraint of time. Can you just speed up on request by the chairperson? Yeah.
Yes, sir.
Thank you,
How many
sir.
centers do this work? Hospital cost, everything. Pharmacotherapy, antifungals, mainstay, antibiotics, all these things. The most two things are posaconazole and amphotericin B, sir. Sir, I started at 12 o'clock. I have not even completed 15 minutes, sir. I don't know who is watching time.
Yes, sir. Please go ahead, sir. But you can speed up, sir.
No.
We want more information.
I'll keep up your expectations.
Yes, sir. Yes, sir.
I was just seeing the time. That's all.
Yes.
No problem, sir. Posaconazole and amphotericin B. Each posaconazole is 500 rupees and amphotericin B is 7,000. You have to give at least 3 to 4 vials per day. And amphotericin is light sensitive and you have to cover with an IV set. Complications are highly nephrotoxic. Almost every alternate day you have to do a complete RFT and LFT, and not in pregnancy. And emerging crisis, another is you need nurses, hospitals, paramedics, and this is the emerging crisis of new car. You need ENT surgeons, physicians, neurosurgeons, maxillofacial surgeons, and all these things are hospitals. It's a big teamwork to face this emerging crisis. What we are. Most important thing is, it's not, this has landed because all these patients are not maintaining their sugar levels. By virtue, if you can maintain below 200 blood sugar levels, no new car will come to you. So, and I don't know, antifungals, government has totally taken over the control of antifungals. Getting an amphotericin B is a Herculean task, and poor diabetic control. People say that world capital is India. Now I can say it will become a galaxy capital or universe capital. And emerging another crisis is cost, sir. COVID, maybe patient may come out even a paying corporate hospital with 3 to 5 lakhs. But a good mucormycosis with a surgery in a corporate hospital, only drugs will cost you about 5 to 10 lakhs, and leave out the surgery. Prognosis, early surgery, good, sir. But late surgeries, mortality is high. What's the solution? No way. Face it, find the solutions, and you have to face the situation, and it's a multidisciplinary approach. Thanks for listening, sir. You have given me 20 minutes time. I have finished in 18 minutes. Thanks for especially Krishna Prashanti, Aivani. Every day I can say hour to hour, they are monitoring the whole system. And once again, it's a wonderful thing for me, for giving me this opportunity to share about mucormycosis. Thank you, sir.
Thank you very much, sir, for sharing all your experience, both clinical approach and highlighting the presentations of the patients at your OP, and your vast experience in performing surgery and your team, and also sharing your video presentations, which has not really worked, at least the slides of this presentation, for enlightening us on the probable best surgery which can be done by you. And I wish all the good luck, sir, for taking care of such good patients, and which is maybe very expensive, as you have mentioned. Thank you very much, sir. We are now going for the question and answer sessions. We would like to look into the chat box, and we would like to see some of the questions. And I request all the speakers to be alert and find out the questions relevant to them. And I find a few of the questions for Last question I would like to see to kindle the discussion. Any information on pregnancy outcome in COVID positive pregnant patients for Dr. Ivani?
Actually, the course of pregnancy, the course of COVID disease in pregnancy is not different from the non-pregnant one. But in the second wave, we have observed that the maternal deaths were higher than the first wave. And all these cases belong to the severe category. So that is my observation. But actually, the study says that the mortality is not very high in comparison to the non-pregnant. But the only thing is pregnancy with comorbidities, they fare badly. Over.
Sir, you unmute, sir. Phanindra, sir.
You have to unmute.
Yeah. Yes. Next question is directed to Dr. Achyut. Regarding what is the best oxygen concentrator and what is your advice regarding what to be purchased at home for home domestic use?
I mean, I must say that I haven't used oxygen concentrators for my patients, but based on the technical knowledge, there are various knowledge I have gained over the past few months. There are oxygen concentrators with varying capacities, and always it's better to have the oxygen concentrator with a good capacity that is at least around 6 to 8 liters of oxygen per minute. And obviously there is another problem attached to this. This is power driven, and we cannot use oxygen concentrators all the time. When you are going for oxygen concentrator, you have to have backup of oxygen cylinder also, so that if at all there is any power disturbance, you can use the patient can get uninterrupted supply of oxygen. So that is what I can say, but I cannot suggest any particular brand, which I'm not supposed to, and also I don't know which brand is good and which brand is not good. But there was another question on oxygen, role of oxygen concentrators in treatment of COVID patients. Post hospital discharge, definitely there is a role. We can discharge patients earlier, otherwise they would be stuck to hospital bed with mounting bills. So better we discharge the patients once they're otherwise stable and oxygen requirement is less than 5 liters. We can suggest them to go for an oxygen concentrator or another alternative source of oxygen and discharge them. And for in-hospital, oxygen concentrators will be very expensive compared to the cylinder supply that is liquid or gaseous oxygen supply. So I hope this answers the question. Thank you.
Thank you, Dr. Achyut. Next question is focused to Dr. Madhusudan Rao garu. At what duration post-COVID is mucor mostly seen? Will it be always have localizing signs, or can it initially present with non-localizing febrile illness? That is a question.
Sir, usually it presents from first week after completion of COVID to within 2 months of post-COVID if they are uncontrolled diabetes. But they can present even after up to 3 months also. And non-localizing signs is, yes, high-grade fever. High-grade fever also to be considered as a non-localizing sign. The other things I think I have explained clearly, the localizing signs to suspect. But the parody is, nowadays patients are coming, there is some blackening of your teeth or alveolus or tongue. Dr. Garu, is this a black fungus? Is this a black fungus? So the awareness is so horrible. Anything black, what you see on the face, they think that it's black fungus.
Yes.
Sir.
To Dr. Achyut, there is another question. Please highlight a bit on HFNC.
Sir, HFNC, it's a lecture on its own, but HFNC is high flow nasal oxygen through nasal cannulae. and it is very comfortable in for certain reasons. That is, the patient can eat and drink while the patient is while getting the oxygen supplementation with some positive pressure, and they don't have to get stuck to the tight face mask, the NIV mask, and it is much more comfortable. But the negative side is it uses a lot of oxygen. And imagine a situation where you're using 40 to 60 liters per minute, and how much does it mount to per 1 hour and 24 hours? It's a lot of oxygen. So that is the problem. But the positive side is very good, and you can in many situations when there is no oxygen depletion, that is we had enough of oxygen throughout thanks to the geographical location. We used a lot of HFNC machines for many of the patients, and thankfully they did very well. Thank you.
Thank you, Dr. Achut. Sir, is there any questions attracting any speaker? I think they can also take a lead, because I'm finding difficulty in focusing to all the questions. But despite that, I found only these. And if anything left out, please you can answer, sir, directly. I request all the speakers to just scroll onto the chat.
No video off.
Okay, Fernanda.
Yes,
Fernanda,
sir.
is that over?
I think it is over. There are no more questions.
Okay,
thank you. Thank you, everyone. Vani, please proceed.
Yeah. So now we'll move on to the third session, which will be moderated Dr. M.B. Vijay Shekhar. So this session comprises of 4 speakers, and over to you, Dr. Vijay Shekhar.
Good afternoon, everyone. And now we have very interesting and important topics in the last session. First among this session, we have with us Dr. Mukherjee, and I think he needs no introduction. It is not exaggerative to say that any webinar which is having a topic or lecture on vaccination is not without Mukherjee. So though he is a senior most interventional cardiologist working in Medicover Hospital, his passion and interest and the knowledge about the vaccination has taken him to such a great height that whenever we get any doubt regarding vaccination, Dr. Mukherjee is always there to clarify the doubt. And he is in this critical periods of pandemic, he has been attending and addressing and clarifying doubts and spreading the knowledge regarding vaccination to several doctors across the globe. So with this brief introduction, I request Dr. Mukherjee to speak his topic on the vaccination, vaccination. Over to you, Dr. Mukherjee.
Thank you very much, sir. Thanks for the kind introduction. Thank you, Dr. Krishna Prasanth Garu, and all the dignitaries on the dais. I'd like to quickly go across to the topic because a lot of things have to be discussed and then the time is constrained. Are you able to see my screen fully?
Yes,
yes.
It is full screen. Is seen.
Before I start, I would like to put a small disclaimer because whenever I'm talking on the media shows, this is what people are expecting me to tell. I have no stock or interest in any COVID vaccine related company. I have no financial gains from the vaccines. I need to tell that disclaimer before I start. Regarding the types of COVID vaccine, now all of us know what are the types of vaccines that we are receiving. The genetic vaccines, the viral vector vaccines, the protein-based vaccines, and inactivated or attenuated vaccines. Attenuated is different from inactivated vaccines. Inactivated means killed vaccines. Okay, the genetic vaccines are DNA vaccines or RNA vaccines. RNA vaccines are mostly mRNA vaccines like the Moderna or Pfizer. The DNA vaccines, the Zydus Cadila company is producing, that is one of the examples of a DNA vaccine. The viral vector vaccines are many, as we know, and the important things are the 2 vaccines that are available with us, the AstraZeneca vaccine as well as the Gamalaya vaccine, also known as the Sputnik V. These two are the viral vector vaccines. And then Johnson & Johnson vaccine, which is given approval for emergency use approval in the US, is also a viral vector vaccine. So is a CanSino vaccine, which is from China. Protein-based vaccines, the Novavax is one of the examples. And the other protein-based vaccine that we'll come across in the inactivated virus vaccines, the most important vaccine, the Chinese vaccines that are available. Okay, what are the total number of vaccinations done in the world so far is a very huge thing, very huge number. And India has put up a huge number of these vaccines. You see, India almost topping the chart in terms of number of vaccines put. It is higher than the United States, it's higher than even the European Union together. Okay, but the important thing is, if you take the percentage of people who are vaccinated, India lags a lot behind. You see, the Israel is way up, United States comes next, and India is just above the world average as far as the percentage of vaccines that are put. If you see another infographic here also, India has given only 3.4% of both the vaccines, and around 11% of its population has received at least one vaccine. That is still far, far, far ahead to go. And whether vaccines work or not, this is what people want to know from me. And the success story of Israel tells us that vaccines do work. But when I say Israel, there are two objections that are raised. One, Israel is a very small country. Two, the other objection is Israel has put totally the Pfizer vaccine, and they don't have either the Bharat Biotech vaccine or the Serum Institute vaccine. So Pfizer vaccine, perhaps that's what you may think. That's why Israel's success story is perhaps we cannot translate it to India. But you see the Scotland, and Scotland also risk of hospitalization fell with almost 85% with the Pfizer BioNTech, whereas the hospitalization fell by 94% with Oxford AstraZeneca vaccine. This is the official figure that they have given. But the Oxford vaccine is restricted only for the elderly in Germany and other countries, whereas it is being given to other population also in the UK. In UK, AstraZeneca vaccine is not given to those people who are less than 30 years. So what do the clinical trials show? The Pfizer BioNTech vaccine is around 95% efficacy. Moderna vaccine is around 94.5% efficacy. Oxford AstraZeneca vaccine is around 60% efficacious. Sputnik vaccine is again published data, 91.6% efficacy, published in Lancet. Johnson & Johnson vaccine, the 66% efficacy in preventing moderate to severe disease, and 85% efficacy after 48 days. That means that with a single dose, after 48 days, very good efficacy rates are noted with Johnson & Johnson. And the Novavax vaccine, 89% efficacy in the UK, whereas the efficacy rates are less with in South Africa. Bharat Biotech vaccine, initially the interim data that was given was 81% efficacious. Later on, the efficacy was given was 78% efficacious in the second interim report. And final results are expected in July 2021. That means that the Bharat Biotech vaccine, Covaxin, has not completed its phase 3 trial yet. That's why US FDA has not given an approval to that. Instead, they asked the Bharat Biotech and its ally, the Ocugen, to go for a BLA, that is biological license application, that involves a full licensing rather than an emergency licensing. Most probably, Covaxin will not get a full licensing in US. Okay, in US FDA, emergency use approval is given only to these three vaccines, the Pfizer vaccine, the Moderna vaccine, and the Johnson & Johnson vaccine. A lot of people are asking me in the debates that how can people produce this kind of a vaccine within 1 year? You are saying that it is 94% effective, 95% effective, but how could they produce it within 1 year? There are a lot of vaccines that which have failed. The GSK vaccine has failed, the Sanofi vaccine has failed, the Merck vaccine has failed, the Queensland vaccine in Australia, surprisingly, has given positive HIV results, and then it has also failed. So a lot of vaccine candidates have failed. It's not that we have brought out this vaccine out of a hat. We have done full diligence and full work. After that, only these vaccines have come into place. That is important. The things that have to be watched out for are, you come from the below, biological E vaccine is going to come in the next month. biological vaccine by E-vaccine is a protein subunit vaccine. It's a protein subunit vaccine. That's why it is different from all the vaccines that we have now, and it is more closer to the Novavax vaccine, and the results are expected in another month. Zydus Cadila vaccine, again, it is different from the vaccines that are using now. It's a DNA-based vaccine. It's a plasmid-based vaccine, and again, the results are expected in a month or two. Sputnik Light is nothing but a single dose of Sputnik vaccine. Sputnik vaccine, as you know, has two different doses. Unlike the AstraZeneca vaccine has 2 doses of same vaccine. Sputnik V initial dose is a different one. The second booster dose is a different one. Initial dose is given with the AD26 virus, and later on dose is given with AD5 vaccine. So AD5 virus, adenovirus. So 2 different doses. So they have studied what will happen if they give only 1 vaccine dose, and then they have found out around 80% efficacy with a single vaccine dose also. But it is very difficult to understand why a single dose of Sputnik V has much more efficacy than a single dose of Covishield, because both have similar platform, both have similar technology, both use a similar virus. So both we expect them to have a similar efficacy, whereas the first dose of AstraZeneca vaccine is not so efficacious. Sputnik V claims that its first dose gives almost 80% efficacy. So Genova vaccine is Indian mRNA vaccine. We should wait for the results. It's still quite far away from this. And Bharat Biotech inhalation vaccine, the results are expected in September. If at all it proves successful, it will prove that the transmission is going to be less with the vaccines. And Vaxart vaccine, the initial results were out, but were slightly disappointing. It is important to know because it's a oral vaccine. Okay, some new concepts in vaccination. Just now, after I entered the session, just before I started the talk, a call came from my auditor. He says that his friend did not get enough antibodies even after both doses, even after 14 days after both doses. Okay, there are many reasons for this. A lot of people are asking me that they don't develop antibodies. Okay, important things are, if you have taken a Covishield vaccine, you will develop only anti-spike antibodies. You will not develop anti-nucleocapsid antibodies. You have to understand which antibodies that the lab is doing. One, if they are doing nucleocapsid antibodies, ask for a spike antibodies. Two, if even if your spike antibodies done, even if they are negative also, still you may have cell-mediated immunity, which is different from the antibodies, and still you may be protected. And ultimately, vaccine efficacy and effectiveness, these are different. Vaccine efficacy means in the clinical trials. Vaccine effectiveness is meaning in the real life situation. Both these are slightly different. I'll explain you why. But the efficacy is good for all the vaccines in preventing hospitalization or death. And that's why even without antibodies also, the chance of you being protected is really high. The other things that we need to note are, if there is an advanced age, they will not get antibodies to the same extent as the young people, and they will not have a similar sort of protection. So they need to be secluded and protected much more carefully than the young. And similarly, the people with immunosuppression and people with the post-organ transplant also, they do not develop adequate antibodies, and we need to be careful. And this is a common question that comes to me. It's a delayed booster dose question. Now, what happens with the Covishield booster? And the durations have been changing. Initial thing was, Covishield was given at 4 weeks duration for all of us. We have taken, and then we have developed a good amount of antibodies and probably some kind of a protection against the hospitalization and obviously death, because I'm sitting in front of you and talking. So the second thing is, after that, the booster dose was delayed to 6 to 8 weeks, because there was a study which was done in UK, which told that the AstraZeneca vaccine works better if the booster dose is delayed to 12 weeks. After that, now the government is saying the booster dose should be given between 12 to 16 weeks. 12 to 16 weeks. Whereas initially, we also presented the data to ICMR and asked them to postpone the booster dose so that more people can take the first dose of vaccine. Now, there is another trial which has come in with Public Health England after the Delta variant has surfaced and dominated the world. Now, the Delta variant is dominating the world. especially in India, also in England. In England also, most of the other variants are going away. Only Delta variant will remain in the next couple of months. And against the Delta wave, a single dose of Covishield has only 33% of protection. And even after both the doses are put together, Covishield gives a protection of around 60%. So there is a need to bring the booster dose closer to the prime dose, even in India, because we have a lot of Delta variant in India. That's what even yesterday also, the government has sat together, and then what they have told is, for now, we'll keep the duration to 12 to 16 weeks only until we see further evidence. We are arguing against it. Let us see. But the problem is, until 12 to 16 weeks, you don't have to worry. There is actually no data for 16 weeks. There is definite data for 12 weeks. So you can delay your booster dose for 12 weeks, but while taking adequate precautions against COVID. That is very, very important. Because the Delta variant can come in even you have taken a single dose of AstraZeneca vaccine. But when you consider Covaxin and Sputnik V, the booster dose remains at the same time. For Covaxin, it remains at 4 weeks. For Sputnik V, it remains at 3 weeks. The Pfizer also is given at 3 weeks. Even if it is slightly delayed also, you don't have to start immunization from the beginning. You can take the vaccine at the same time. Because a lot of people are asking, I have taken Covaxin until the next 6 weeks, I could not take any other booster dose. Shall I take the first dose again? You don't have to take the first dose again. Take the second dose of booster dose, that will be sufficient. Okay. The single dose for already infected, this is an important topic that is coming up. There is actually new data now, which says that infected people don't require a vaccine at all. This is the new data that is coming up. Because already infected people have almost 83% protection at 6 months. That is the data from Siren study from UK. So definite evidence of protection from a previous infection is there. And do they really require a booster dose? Actually, they do require a booster dose because the Siren dose study was done in those people who have neutralizing antibodies. Not all the people who are infected, mind you. They have done a booster, they have done antibody levels, and in those who are seropositive, they have 83% protection, and not all the people who are infected. So all the people who are infected should definitely take at least 1 dose until further evidence emerges. And WHO about the variants, there are a lot of things that are going about the variants, and then the variants of interest and variants of concern are different. There are a lot of variants of interest, and some of the variants are under investigation. But variants of concern should concern us. These are the alpha, the beta, the delta, and the gamma. These are the variants that are there, and we have to be cautious about them. And the vaccination against the variants, almost all the vaccines are effective against the initial mutant, that is D614G. Unfortunately, WHO did not give any Greek alphabet for the Chinese original variant of the disease. I shouldn't say Chinese, but the original D614G, that variant, there is no name given. Alpha starts with the UK variant or the B117. So the future generations may think that the virus origin was B117. That's why we should also ask the WHO to name the D614G also with a Greek alphabet. So the alpha variant, almost all the vaccines are effective against, but Delta variant, almost all the vaccines have reduced efficacy. Even Pfizer vaccine has a reduced efficacy. Oxford AstraZeneca vaccine, I've already told. The Covaxin, initially they have told that it is 1.95 times less effective with the Delta variant. Now new data is coming, which says it is almost 2.4 times less effective for the Delta variant. And then the Bharat Biotech vaccine is against alpha variant is effective. This is very important. I'll reiterate again, Oxford AstraZeneca vaccine that is available with us gives only 33% protection after the first dose and almost 60% protection after the second dose. There are some important questions that people ask me. I'll quickly run through this because I have less time. Please don't mind the speed. Vaccination during menstruation should be given, no problem. Lactating mothers should be given, no problem. Pregnant ladies, there is definite data in 30,000 people with mRNA vaccines like Pfizer and Moderna that they are safe, that they can be given in pregnancy, but we don't have data with Covishield or Covaxin or Sputnik V. That's why I have asked the government of India to reserve the Pfizer vaccine doses to pregnant ladies as well as obese children and children with other comorbidities. And vaccination for people with heart disease should be given, not whether it is optional, it should be given. Vaccination for people on blood thinners, no need to stop antiplatelets, anticoagulants, newer anticoagulants, you don't have to stop, you can continue. The older anticoagulants like warfarin or acetrom, you measure the INR, if the INR is less than 3, you can safely give. And then people who have allergies, you can safely give the vaccines. People who have cancer, you can safely give the vaccines, but the problem is they may not develop adequate antibodies. We have to be careful in asking them to follow COVID appropriate behavior even after vaccination. Post-transplant, again, you can safely give, but the problem is, again, they may not develop adequate antibodies. Food allergies, you can give safely. Skin diseases like psoriasis and eczema, you can give safely. People with asthma also you can give safely, but people with anaphylaxis to any injection, especially vaccination, they should be cautious and they should not take the vaccine. That is important. Can the vaccines stop transmission? That is the question that is being asked. And important thing is 49.3% reduction in transmission has been noted with Oxford AstraZeneca vaccine, and 2/3 drop, almost 66% drop is there with Moderna vaccine. And some sort of protection is needed even after a vaccination. We should wear our mask definitely after vaccination. We don't have mRNA vaccines. The vaccines we have protect us around 70 to 75%. So we need to wear the mask and we need to be careful. CDC Atlanta recommends that those who are fully vaccinated can remove the mask and come out into the public. In India, we cannot expect such a guideline anytime in the future. So you stick to your mask, like Dr. Ramani is wearing even in the webinar. Anaphylaxis following vaccination, it's very rare in India, I should tell you. Even in US also, it is 11.1 per million doses. But in India, the anaphylaxis dose is much, much lesser. The approaches to treat vaccine hesitation, it is very, very important. These approaches are science, education, access, civil discourse and debate, and then never coercion or censorship. Even when people who are not qualified also are questioning about the vaccination, we have to stay there patiently and explain them, but we should not lose our patience. It is through civil debate and discourse only we should promote vaccination, not through any means of coercion. Vaccine-induced immunothrombocytopenia, this is the clots after AstraZeneca vaccine, everyone is worried about. And then it is 3.6 per million for AstraZeneca vaccine, very, very rare. And with the Johnson & Johnson vaccine, it is only 0.9% per 0.9 per million. And in India, it is even more rarer according to the ICMR. It usually happens for 5 to 42 days after vaccination. And if at all you have a case, you should immediately check the platelets. And the platelets are less, don't go for platelet infusions. Avoid heparin and then give newer anticoagulant agents or fondaparinux and start IV immunoglobulin. These patients become better. Myocarditis following mRNA vaccination, this is coming up in a big way. Now mRNA vaccine, US, everyone is asking about myocarditis, and it is very rare. 226 cases only are reported in less than 30-year-olds only it is reported. And 80% of them, unlike the normal cases of myocarditis, these people recover spontaneously without anything. Breakthrough infections, this is the debate that is going on, that the Delta mutant will come regardless of your vaccinations. Some people say that your vaccinations are placebos. Please listen to this carefully so that you can counter them on social media, you can counter them on TVs. The CDC says only 10,200 cases are reported. When you consider almost 150 million people that are vaccinated in the United States, the number is only 10,000, it is very less. And mortality is around 2%. One person has questioned me, if the mortality for a breakthrough infection after vaccination is 2%, and in general, if for those who are infected, the mortality is around 1%, why should we take the vaccines? You understand this question carefully. What the question is, breakthrough infections, the mortality rate is 2%. natural infections, the mortality is 1%. How can you say that the vaccination is better? I'll come back to it. It is a very important question. You should be prepared to answer that. The average age of people who died is around 82 years in the CDC trial. And then one more important trial has come up, Apollo Health Worker study done in India. They said that the protection from infection after vaccination is 97.38%. And then the hospitalization required was only 0.06%. NEJM has published that the breakthrough infections in the real world are higher for post-vaccines rather than in the clinical trials. The breakthrough infections are 1.19%. PGA study, they say that 1.6% of the people who take both the doses of vaccine can be infected, but 6.4% of those who are unvaccinated got infected. This is more in line, this is the India data. If you are not vaccinated, the risk of infection is around 6.4%. If you are vaccinated, the risk of infection is 1.6%. And then Fortis trial, this was published actually in Diabetes and Metabolic Syndrome Clinical Research and Reviews. 113 people were vaccinated, and the infection is breakthrough infection is only 13.3%. It's quite high when compared to the other trials. AIM study, you'll have to listen to this. What they said is 63% of breakthrough infections, 53 have received Covaxin and 10 have received Covishield. Sorry, this is the other way around. 33 people were given 2 doses, and then the B16172 and B117 are the main variants. And then next day, this is what newspapers have reported. COVID-19 Delta variant can infect vaccinated people. Delta variant can infect vaccinated people. Every news channel has reported this news. But this is not what the AIM study means. AIM study did not study 100 people who were vaccinated, who were sent into an area of alpha variant, and 100 other people who are vaccinated and sent into a Delta variant zone. What they have studied is, they have taken all the breakthrough infections and then they studied genetic mutations in them, and then they found out that Delta variant is there predominantly among these breakthrough infections. For example, if in the outside world, breakthrough infections, if in the outside world, Delta variant is more common, even in breakthrough infections also, Delta variant will be more common. And that is what has happened in AIM study. In Delhi, the study is 60% infections are through Delta variant only. So even in breakthrough infections also, you will see more number of Delta variants. There is nothing unusual about it. It doesn't mean that the Delta variant can infect vaccinated people. No, this is the counter narrative that we have to give to the television channels and the media to fight the misinformation and immunize people not only against the COVID, but also against the misinformation. CMC study, again, 94% protection against the ICU admission, and then the 65% protection against the vaccination. Nagpur study, this is released only today. Only today this has been released, and the infection rate is significantly less in those who are vaccinated. Hospitalization rate is less. Severe disease is 0 with the people who are infected after vaccination. So it is important to see that the breakthrough infections can be there, but the mortality will be less than those people who are unvaccinated. Now I'll come back to the question, why the mortality is high in breakthrough infections rather than infections acquired in the community without vaccination. Number one, people who have breakthrough infections are in general old and debilitated people who did not develop adequate antibodies from vaccination. Number one. Number two, more number of elderly are vaccinated upfront in all the countries, including India. More number of elderly people were vaccinated. Number three, more number of healthcare workers and frontline workers are were vaccinated who have a higher viral load if at all they get infected. So post-vaccination disease has a higher viral load because the people who are vaccinated work in high-risk environments. Vaccinations were given to high-risk people to start with, and people who did not develop adequate amount of antibodies because of comorbid illnesses or concomitant medications, they get the breakthrough infections and they have a higher mortality. This is the reason why the breakthrough mortality is higher. And now I'll come to bring to your attention, this is almost the last slide, please bear with me. This is the table 6 of Public Health England Technical Committee report released yesterday. This is important for you to understand that they are studying the Delta wave in ways that we never could have imagined. they are getting real-time Delta variant information, because in India, we have to do sequencing to tell whether a variant is Delta variant or not. But what they are doing is they have developed what are known as SNPs, single nucleotide peptides. And with that, with serological studies only, they're able to tell which is a alpha variant and which is a Delta variant. And then they have a real-time information. Up to 7th June, what they have given is there were 42 deaths in people with COVID. And then among these, 12 deaths happened in those who were given both the doses of vaccines, and then after 14 days of that. See the last row. This is what every Tom, Dick and Harry is going to question you over the next 3-4 days. This is the Public Health England data. And then in that data, what they are saying is total number of deaths are 42, and 12 deaths happened in those following 2 doses of vaccinations. That means a high number of people who died have come from the vaccination group. This is the counter to that. All the people who have had vaccination are very elderly in England. And then in these people, the breakthrough infections, for whatever reason, if the antibodies don't develop, they are developing their breakthrough infections. That's why they have done an analysis. One, I forgot the name, Robert Wade, I believe. One mathematician is there in the UK, and he has done an excellent analysis. I have put up on my Twitter line, where he has told bit by bit why this data cannot be interpreted as vaccines do not work, and why this data exactly tells you that the vaccines work. That is very important. And this is what I'll conclude my talk with. I'd be happy to take any questions regarding vaccinations. Thank you very much. And sorry for being so rapid. I hope I could convey a point or two.
Yes, thank you, Dr. Mukherjee. Wonderful session. People are really interested to know about all the facts you have enumerated nicely. And I request you to please stay back, because we'll be taking the question answer sessions after all the 3 sessions. Because we have 3 more sessions, and I think Dr. V. Sudhakar also has joined. Sir, are you there? We have Dr. Krishna Prasanthi and also Dr. Next speaker. Thank you, Dr. Mukherjee.
I'm Dr. Suresh Kumar. I'm here.
Yes, sir. Yes, sir.
Now
I invite, yes, sir. Dr. Suresh, welcome you, sir, for today's CME, and he is a very renowned psychiatrist, and he is from Guntur, and he will be talking about the healthcare stress management in the healthcare workers. Dr. Suresh Kumar.
Thank you, sir. Good evening, everybody. Thank you for the IMS specialties for giving me this opportunity. And after the elaborate and detailed lecture of Dr. Mukherjee sir on vaccines, probably my lecture will pale off. But anyway, the stress management is important for the healthcare workers, especially undergoing a lot of stress. As itself, our profession is daily stressful. And to this, my talk I dedicate to the people, the Corona warriors, more than 646 doctors who have died. This is a 1 week back slide prepared. It must have now has crossed 700. For all those doctors, I dedicate this talk, who has worked hard and who has left their life to look after some other people. With this type of PEP kits, even I put a mask for 1 hour, I feel little suffocated. But these people put the total PEP kit and work without taking food, without going for urination, and really hats off to these people. Of course, in view of these things, we have gained some awards and rewards for these people's industries. So this is one where the Superman, Spider-Man, all the so-called comic figures bowing heads to the doctors. And this is how doctors saving the people. What a great picture, which shows how a doctor is trying to save life by not caring about his life. And of course, Mahishasura Mardani, that is Corona Mardani, who has been doing a lot of work leaving aside the family, leaving the children. And this picture is the best picture I can say. And this has happened. It's not something just imagination. One anesthetist who has been admitted with COVID in an ICU with a ventilator, he has arranged a ventilator for a patient, and hats off to them. And we stay here for you. That's what doctors say. Please stay home for us. And this is Corona survivor, 103-year-old Janaki Ammal, who is saluting the doctors, and doctors are wishing her full health. So these are some rewards which we got. Of course, recently we have been receiving a lot of brickbats, people criticizing us, medical mafia, Dawn, what are those words? I don't know. The TV people trying to highlight for their TPR. And this is what is happening. And in the first wave, a lot of doctors were asked to evacuate from their own apartments. My own postgraduate students one day called me up and said, "Sir, we are asked to evacuate from the apartment. What should I do?" Then I said, "You can consult your management. I will contact the management. Meanwhile, you can come and stay in my nursing home on the top floor. 3 rooms are there." And luckily, the management of Katuri Medical College arranged rooms for them. So that was the situation where people were isolated, evacuated. Doctors who were seeing the people, who were examining, who were taking the risk, they were treated like this. And that resulted in a lot of stress among the young doctors. And yesterday, we have seen that beautician of Hyderabad, who was giving a very much, I think we should call her Sahajanati, curious cases of Indian variant split personality disorders. Please save my brother doctor, he needs oxygen, he needs ventilator, he needs ICU. And at a later time, again, the same fellow will say, "You have killed my brother, and I have brought him in a complete healthy situation." The person who said, who needs ICU, ventilator, oxygen, now says that he has brought in a healthy condition. This is what that beautician from Hyderabad was saying. And you know, lot of physical handling, manhandling of doctors has occurred. And because we are, those people are the first contact between the doctor and the patient. So immediately if something happens, they immediately blame the doctor. When oxygen was over in a lot of places few weeks back, when the doctors were trying to revive the patients through external cardiac massage and even through mouth inhaling, these relatives got so annoyed and bet the doctors who were trying to save the people. If the oxygen is not available, is it the doctor's fault? No. But all that aggression is directed towards the doctor. And this is the same thing which I was talking about, the beautician, where the hospital was ransacked with so much hard work being put up by the COVID doctors. Is it the result that they get? Is it the benefit that they gain? Anyway, our state leaders, our great leaders of Indian Medical Association, both state and central, have fought off, and now it has been made an offense legally to ransack a hospital or manhandle a medical professional person, whether a doctor or nurse or whoever it is. And thanks to their hard work, we have got that rule which will protect us, partially at least. Now they are liable for imprisonment for 2 years if it is a first attack. They are also liable to pay 10 times more to the damage that has been done to the hospital. Why has it happened? Ours is such a noble profession. At one time, we were placed on the high pedestal. We were considered as demigods. But why? Why is there so much anonymity, antagonism towards doctors? Changes in the society. We are not isolated. Changes in the society has peeped into our profession. Patient has become a consumer. He has become a shopping. Doctor shopping is now his right. And doctor has become a service provider. Corporatization of the medical field. Of course, there are few black sheep in any profession. And of course, medical profession has very few black sheep compared to any other professions. And who is responsible? Professional jousting. This is another important thing. The moment the person goes for a second consultation, Immediately the second doctor says, oh, that fellow doesn't know anything. He was my student. He passed very hardly. I made him to pass. So these are the comments which are given by the other doctor. That is what we call as professional jousting, which is one of the major culprit for our problems. Of course, society expects a lot of things, and our own advertisements like guaranteed treatment and patients over expectations. Because of these things, when a patient is said, relative is said, we have a ventilator, ICU, everything, they believe that their death is not going to happen. But we are trying all our best. But once it happens, after spending a lot of money, they get too much annoyed and they project that hatred towards the doctor who is in the first point. We are expert clinicians, but poor communication skills. When we are spending so much time on the service of the patient, spend 2-3 minutes with the patient relatives every day. You go out, you explain to the patient relatives, or let your junior doctor explain the prognosis to the relative every day. Then relative will have happiness. Otherwise, they think they have put in ICU 2-3 days, since 3 days, nobody knows what happened. He must have died, still they are charging. This type of remarks are coming because of lack of communication. Now, that is very important. And what are the sources of stress? Workload, time pressure, administrative duties, sleep deprivation, no regular meals. In fact, doctors are called Sunday fathers because they are seen only on Sunday by their children. The other days when the child wakes up, the doctor must have gone home. And predominantly personality, demands and others, dealing with death and dying. So this is to prevent that. You have to recognize the stress, reverse it, and resilience. Avoid the stressor, alter the stressor, adapt to the stressor, accept the stressor. Things which you can't change, don't go on wasting your time. Learn how to say no. It's an art without damaging the other person. Avoid people who stress you. Alter the situation. Try to be compromised. If you want some other person to be compromised, you should also compromise on some situation. And become assertive sometimes, not aggressive, but you should assert yourself. And adapt to the stressor, reframe the problem. Accept the things that you can't change, which is not in your hands. Don't break your head. Nurturing yourself is a necessity, not a luxury. You have to nurture yourself first. You are working hard, you are earning money. For whose sake? You should also enjoy a little. Go for a walk, spend time in nature, call a good friend, sweat out tension with a good workout, take a long bath, light-scented candle. So body, intellect, emotions, and spirituality. Take a proper diet. Exercise is the best medicine. Train to relax. Avoid alcohol, cigarette, drugs, which cause temporary relaxation. Analyze the nature of your problem. You should know the difference between right and wrong. Do what you want and what is feasible and what is possible. Keep busy at your work. Increase your self-confidence. Just like the cat seeing in the mirror feels lion. Engage in social service. Pursue a hobby. Any age is not a bar for any hobby. Don't think because you are 60 plus, you can't do this. See, this is the thing in IMA. This is 100 kilometer cycling after 60 age. I have done it with my co-cyclists and dramas. All these things are stress busters for me. Control your anger. Don't go to a nutshell. Share, share, share. Share with friends. That is the mantra. Music can do wonders. Enjoy the music. Play the music. If you don't know the music, hear the music. Cut jokes on yourself. Cut jokes on colleagues. Cut jokes on your profession. But don't comment on people who are crippled or blind. Reach out those close to you. Whoever are close friends, spouse, children, friends. Share with them. Don't think that you are burdening them at all. Be more sociable with your co-workers. Limit your contact with negative people. Identify those negative people who create aggression, anger in you. Avoid them as far as possible. Giving will give you a lot of things. Power of giving. Nourish your body. Exercise releases hormones and increases the immunity. Create reward system. You have done something, enjoy yourself. One patient has been saved, pat yourself. pat your back, and take care of your body. It is the only place you have to live. And express your feelings. Enjoy small things, the nature, bird chirpings, talking to your child, hearing the music. Don't overload yourself. Don't overstretch yourself. And finally, Lord Krishna, Bhagavad Gita, the message to the doctors. Don't think of your past patient. Don't think of your future patient. Just think of your present patient. When you were not there, this hospital was functioning. Even when you leave, this hospital will function. So nothing is indispensable. So don't overwork, overstrain, and allot something for your family, and family balance is important. The patient who is yours today was some other's patient yesterday, and tomorrow he will be some other's patient. What you think yours is not yours. So just this is what you need to keep the stress out. And thank you for giving me the opportunity again. Thank you very much. Thank you. I think I have finished in the time.
Yes, sir.
Thank you, sir.
Sir, really that was a wonderful presentation, sir. I think this is very, very interesting among the today's seminar. And you have rightly quoted, sir, the last but one slide, the Bhagavad Gita. And also you have nicely narrated the patients and their attendants' perspective. Just like the slides are also very excellent, sir. Aparachitulovi. They speak on the mana real life lo chuse sir roju avannenu. So and Dr. Sir Sunday's father. Some of the really good quotes, sir. And so that shows the maturity, and it shows sir is a very famous psychiatrist. He was a past secretary, past president of IMA Guntur, and he was also the state president of Indian Academy of Psychiatry, and he has several other feathers. Anyhow, wonderful session, sir. Thank you very much. We now proceed to the next, sir. Sir, I will be putting the chat box questions in the last, sir, after two more speakers we have.
Sure, sir. Thank you very much.
It is now my privilege to invite the next speaker, and it is none other than our Dr. Krishna Prasanthi. She will be speaking upon on the post-COVID management. I think she needs no introduction. She is an active member of IMA and also the Women Doctors Association. She is a senior consultant physician from Harshita Hospital, Tirupati, and incidentally, she is the chairperson of Academy of Medical Specialties and also the vice chairperson of APAPI, and she is the treasurer of Research Society of Society of Diabetes Mellitus also. I think she is ready, Dr. Krishna Prasanthi. And before that, I just want to check whether Dr. Sudhakar, sir, speaker. Sir, you are ready? Okay.
Vijay Shekhar, am I audible?
Yes, sir. Yes, sir. You are audible. Sir, right. After the present speaker, yours will be the next one, sir. Thank you. Okay. Now over to you, Dr. Krishna Prasanthi, for the post-COVID management. So, I think Madam is about to start. Before that, as we all have seen, first wave is over, second wave also is coming to an end, and now the post-COVID effects are being seen more and more. And one such is the post-COVID syndromes, early, late, and persistent syndromes, and also, of course, some effects of this post-COVID in the way of mucormycosis. We all have been listening to these.
Yeah. Good afternoon, everybody.
Yeah, Dr. Krishna.
Sir, am I audible, sir? Is my screen audible? Visible, sir?
You are audible and the slides are also visible. Please go ahead.
So, first of all, I thank Dr. Vijay Sagar, sir, for your kind words of introduction. Slide sharing. Let's slide. So, on behalf of IMA, AMS, AP State, I salute to all the COVID warriors And my heartfelt thanks to all the healthcare workers standing on the front lines of this corona pandemic. I thank all the guests and panelists for today's CME. So today the practical issues what we are supposed to be concerning are what exactly is the post-COVID, how long we have to take. So normally there are a lot of definitions. Now there is no exact guidelines, but what the NICE guideline says is, I think after 12 weeks you can take it as a post-COVID. What is long COVID? There are so many terms like post-COVID, long COVID, chronic COVID. Like even after 4 weeks of getting the infection, if the virus is shedding and the patient is symptomatic, after 4 to 12 weeks, we can take it like a long COVID. How do patients present in this recovery period? How do we diagnose these complications? When to do the repeat biochemistry test after follow-up? When to do the repeat CT scans, how long we need to follow up. This is only a bird's eye view because there are no exact definite guidelines over this. This is my own patient, a 38-year-old male, obese, diabetic patient, presented to our OP with papular rash and acneiform rash, blood sugars of fasting of 334 and postprandial of 450. He recovered from COVID infection 15 days ago, admitted with oxygen supplementation. He is not in ICU. Complaining of severe weakness, he is unable to attend his marketing job. His wife is a nursing staff and taking care of him meticulously. This is how he came to me 2 days ago with all this rash. And we know that many of the people who are on steroids in the post-COVID phase, they are coming with acneiform eruptions, skin lesions, and patient is more worried about this. And patients are coming with high blood sugars. This is one thing which we have to consider. Patients are complaining of severe weakness. This is also a point of concern in the post-COVID management. This is another patient, a 55-year-old female who is a known diabetic, hypertensive, presented to us with discoloration of toes since 5 days. She recovered from COVID 10 days ago in a tertiary care institution. Meanwhile, that means she is on antiplatelets, but she was not on anticoagulant. She is having fever, cough, exertional breathlessness, and worried about the removal of her leg. So this is how the patient presented to us. So these days, people who got mild COVID or moderate COVID or a severe COVID, or patients who are in home isolation or in quarantine, or patients with various clinical manifestations are coming to various specialists with different kind of manifestations and presentation. That we know that what are all the stages of this COVID infection. So the incubation part, the symptomatic part, the early pulmonary phase part, the late pulmonary phase part, everything is there. But almost we see the total duration of illness comes around 28 days, and patients may have different clinical manifestations, and patient may have a progressive hypoxia. But if you see exactly the demarcation, the acute COVID and the post-COVID-19, it is from 3 to 4 weeks, the clinical features may be changing. RT-PCR can be negative and patient may not be having any manifestations. Slowly, the patients can have different manifestations starting from fatigue, decline in quality of life, muscular weakness, aches and pains. Patient may be having dyspnea on exertion, on doing their routine work. Patient may be having a shallow cough or a dry cough or a little bit of a persistent cough. Some patients may be needing on the domestic oxygen supplementation. And most of the times patients are having anxiety, depression, sleep disturbances are extremely common in the post-COVID. Post-traumatic stress disorders are very common. The brain fog is a term for the cognitive disturbances. Even some cases have been reported with the hearing disturbances. Headaches are very common. And the most important common manifestation in the post-COVID is the palpitations, vague chest pains, and various thromboembolic manifestations from cerebral to coronary to renal to peripheral vascular diseases. Patient may be having a CKD patients or a mild renal impairment patients, and there is a cases of significant hair loss. So the patient may be having acute, post-acute COVID-19 or a subacute ongoing COVID-19, or the patient may be having chronic post-COVID-19. So we take from 4 weeks to 12 weeks, and there are case reports that these symptoms can persist from 3 months to 6 months also. So we can't usually say that after home isolation of 14 days, after you are discharged from hospital, you will be absolutely normal. So a regular follow-up, an eye on these clinical manifestations and atypical presentations, up to 6 months follow-up is needed for a patient who got COVID-19 detected. So we see what are all the acute complications. Everybody knows neuropsychiatric, CVAs or encephalopathy or delirium. Most of the patients in the first wave, they used to have the recovery of the smell sensation and the taste sensation within 5 days to 7 days. In this second week, they are having almost up to 1 to 2 months. They are not having the recovery of the symptoms. Patients are having high chances of the secondary bacterial infections. There are patients of having high ARDS and hypoxemic respiratory failure. Arrhythmias are very common. Bradyarrhythmias, tachyarrhythmias, viral myocarditis very common. Even stress cardiomyopathy is also common in the COVID-19. Hematological manifestations, coagulopathy, thrombotic events, AKI, and the abdominal symptoms are very common in this secondary wave. Diarrhea, pain abdomen, vomitings, rise in liver enzymes, acute liver injuries have been seen. Musculoskeletal manifestations are common and various dermatological manifestations are seen. Post-COVID symptoms, the one most important thing is the cognitive disturbances have been reported, mood changes, sensory and motor deficits, chronic fatigue and sleep disruptions, persistent dyspnea and chronic cough, vague chest pain and palpitations, recurrent thrombotic events and CKD patients, liver disease patients. Muscle wasting is one of the important things, the sarcopenia. Almost 10 to 12 kilos of the weight loss have been seen. Progressive increasing fatigue and weakness has been reported in many of these patients. If you see the most common pulmonary manifestations, the first and foremost is the decreased exercise capacity and hypoxia are commonly persistent symptoms and signs. There is a reduced diffusion capacity, restrictive pulmonary physiology, and sometimes even the ground glass opacity and fibrotic changes have been noted at follow-up. Some people are in habit of taking repeated CT scans to see the resolution of this, which you can't expect within 3 to 6 months. Assessment of progression or recovery of the pulmonary disease is very important. We have to advise the home pulse oximetry. 6 minutes walk test is very important. If there is a need, we can go for the pulmonary function test, high resolution CT scan of the chest and CT pulmonary angiogram. If needed, we have to go. So we can have a mild symptoms, we can have all these changes, and we can do the investigations depending on the clinical condition only. So there are patients who need supplemental oxygen, breathing supports while sleeping is needed for some patients. Oral corticosteroids like prednisolone can be given for at least 1 to 2 months depending on the clinical condition. Antifibrotic therapy like pirfenidone has been tried in some of the patients. It has been given in the idiopathic pulmonary fibrosis, but it has been tried in this COVID-19 because it has action on the inhibiting the collagen synthesis and block the fibroblast proliferation. Pulmonary rehabilitation is a very important. We have to do for at least 3 to 6 months, and patients can be advised on this regular follow-up. The other important complications are hematological manifestations because less than 5% of the post-COVID patients are having thromboembolic events. The duration of this hyperinflammatory state, we don't know whether it's 2 weeks or 2 months. Direct oral anticoagulants and low molecular weight heparins may be considered for extended thromboprophylaxis after risk-benefit discussion in patients with predisposing factors for immobility, persistently elevated D-dimer levels greater than twice than the upper limit of the normal, and in another high-risk comorbidities like cancer. We have to go for the oral anticoagulants, novel oral anticoagulants, apixaban 2.5 per oral BD or rivaroxaban or dabigatran, depending on the condition of the patient for 2 to 3 months. Role of antiplatelets is controversial, but still aspirin has been given for 75 mg for many of the patients. Those patients who are on antiplatelets like aspirin, clopidogrel or prasugrel can continue depending on the, we have to go for the prothrombin time and APTT estimation in case of any bleeding manifestations. And most important thing is patient should not be bedridden. A simple ambulatory techniques or a physical activity has to be encouraged in many of the patients. What are all the cardiovascular manifestations? Persistent symptoms like palpitations, dyspnea, chest pain are very common. Long-term sequelae may include increased cardiometabolic demand, myocardial fibrosis or scarring, arrhythmias, tachycardia, and autonomic dysfunction. In our post-COVID OPs, we are regularly seeing patients coming with different arrhythmias and palpitations. Patients with cardiovascular complications during acute infection or those experiencing persistent cardiac symptoms may be monitored with with serial ECGs and echocardiogram follow-ups. Sometimes in the case we need to go for a low dose of beta blockers like bisoprolol can be given in those patients. Like neuropsychiatric manifestations, what we have been discussed earlier, like fatigue, myalgias, headaches, dysautonomia, cognitive impairments, brain fogs, anxiety, depression, sleep disturbances, and PTSDs have been reported to 30 to 40% of the COVID-19 survivors. What my previous speaker, Dr. Suresh sir, has told, these are all the things which we have to consider, because all the pathophysiology of the neuropsychiatric complications is it's diverse and entails the immune dysregulation, inflammation, microvascular thrombosis, iatrogenic effects of the medications, psychosocial impacts of the infection. It could be the economic reasons, it could be staying alone in the hospitals, it could be spouse death or something, it could be loss of family members. So many causes should be there. So not writing the mere prescription, we have to take care of these things when we are taking care of this post-COVID neuropsychiatric manifestations. So chronic headache, treatment of anxiety, depression, sleep, and psychological counsel is very, very important. Previously, our family members and friends used to do physically when the patient is sick. Now it's WhatsApp and video calls we are doing. That also has to be encouraged if the patient is not having in a sound mental condition. Renal manifestations, resolution of acute kidney injury during acute COVID-19 occurs in majority of the patients. However, reduced eGFR has been seen at 6 months follow-up. COVAN is a COVID-19 associated nephropathy. It's a type of collapsing glomerulopathy. It's a predominant pattern of the renal injury in individuals of African descent. Even COVID-19 survivors with persistent impaired renal function may benefit from early and close follow-up in AKA survivor clinics. So the most important is it's not only the measuring the blood urea and serum creatinine, serum electrolytes, we have to estimate the regular eGFR and we have to titrate the doses of the oral anti-diabetic drugs or antihypertensive drugs. Post-acute COVID-19 endocrine manifestations, everybody knows the therapy for the diabetes mellitus. Those who are non-diabetics are becoming newly detected diabetics. Those who are pre-diabetics are becoming full-blown diabetics. Those who are non-diabetics are becoming poorly controlled glycemic manifestations. Many of the patients are going for a hyperglycemic emergencies like diabetic ketoacidosis. There is a variation of the thyroid dysfunction. Subclinical hyperthyroidism is also very common. Vitamin D COVID is again a very big topic. Now that many studies have been conducted regarding the high dose vitamin D supplementation in COVID-19. The important study has coming from the PG Chandigarh. So this is one of the things Dr. Ashu Rastogi has given the guidelines for giving the vitamin dose for acute COVID-19. So patients with newly diagnosed diabetes in the absence of traditional risk factors for type 2 diabetes, suspected hypothalamic pituitary adrenal axis suppression or hyperthyroidism should undergo appropriate laboratory investigation and regular follow-up. So I'm not going in detail of this thing. If the patient is not on good control with oral anti-diabetic drugs, you are justified in giving insulin for at least 2 to 3 months. That is the best way of getting the good glycemic control so that we can decrease the increasing incidence of the fungal infections and mucormycosis. Monitoring of thyroid dysfunction is very, very important. Vitamin D supplementation, adequate dose and adequate levels to be monitored depending on the need of the patient. And GI manifestations and hepatobiliary manifestations, prolonged viral fecal shedding is occurring in COVID-19. So this is very, very important in telling the patients regarding the sharing of the bathrooms in the domiciliary care when the patient is in the isolation, in the post-COVID follow-up. This is one thing which we have to take care of our patients. COVID-19 has a potential to alter the gut microbiomes, including the enrichment of opportunistic organisms. We are seeing increased incidence of candidal infections and depletion of the beneficial commensals. Any viral infection will increases the liver enzymes transiently, but if the pre-existing hepatic disease is there, we have to take care of them. And dermatological manifestations, hair loss is very predominant, rashes are very predominant. In the mucormycosis, I'm selectively excluding because my previous speaker has given the detailed description. Any blackish discoloration of the skin over the toes, over the extremities, over the tip of the nose, that we have to consider. So this is one thing as a part of the completion. Multi-system inflammatory syndrome in children. Previously, when we are talking about the Kawasaki disease like that, we are thinking about the less than 7 years. Now, even the patients in the adolescents like that, even less than 21 years, we are seeing the patients with fever, elevated inflammatory markers, multiple organ dysfunction, and a recent SARS-CoV-2 infection, and we have to exclude the other plausible diagnosis. There could be cardiovascular involvement, neurological involvement, and so many complications is there. So there is a transition age between less than 12 years pediatric and adult, but these patients also probably pediatricians and physicians will be seeing. So we know that various manifestations are there from general to extrapulmonary, which speaker has given a very important thing. I think the categories what ICMR has given, told by Dr. Murthy, which we have to consider any atypical neurological manifestations like GB syndromes, encephalopathy, sudden collapse, all these things we have to suspect COVID in the pandemic. So we need to have a multidisciplinary clinics. We need to have a teamwork. We have to go for a systemic follow-up. We need to go for a pulmonary and a cardiovascular assessment. You have to go for a 6-minute walk test. If you go for a simple chest X-ray, you can go for a echocardiogram, and if needed you can go for a HRCT, and you screen for a mental health questionnaire can be taken, a simple albumin excretion can be taken, and you can go for a rehabilitation and patient education. And what else, there are lots and lots of things are pouring on in the social media regarding the supplementary therapies, which we don't want to comment. Nutrition is very good. What is the best nutrition? You want to go for a nutritional supplements, you want to go for a nutraceuticals, you want to go for a vitamin C, vitamin E, all that is there. Whatever you take, it's a balanced diet. Because of your distaste, because of your dyspepsia, you are unable to take whatever you want to take. Whatever you take, depending on your renal status, depending on your hepatic status, depending on your diabetic status, depending on your lipid status, take as normal as possible. If you are unable to take, at least whatever food is given by your doctor, you can take. And don't go on mixing so many nutritional supplements, Ayurveda, homeopathy, allopathy, whatever is there. Take plenty of vegetables, fruits, and a limited diet. Go for a simple exercise. Even if you are in a room, a simple walking for 10 to 15 minutes is essential. A simple pranayama exercise, yoga, or listening to music itself is sufficient, because you should be mentally fit, you should be psychologically fit, you should be emotionally fit, and you should be biochemically fit in the post-COVID period. Because what is to be done, lot of questions are coming regarding the IgM and IgG antibodies. Are they really justified that we are going to recover post vaccination? Once first dose of vaccine has been taken, patient is going for long COVID, whether they want to take revaccination or not, whether the patient want to go for the antibody estimation, how long these antibodies will be persisting, is up to week 4 or week 5. Really the value of the antibodies will affect the amount of the protection we are having. All these questions are still unanswered. So instead of going on repeated testing with IgG, IgM antibodies, instead of going for repeat RT-PCR repeatedly every week like that, you go with your clinical manifestation, a simple biochemical test of CBC and your CRP. If you are in a risk group like a D-dimer and a ferritin, if you are having any progressive cardiac or pulmonary symptoms, you can go for your routine follow-up. At least every 2 weeks, you should be having all these tests depending on the clinical condition. So you need not go for all the tests for all the people, depending on the severity of the disease, depending on your clinical condition, depending on your recovery. So what are all the points of concern in the post-COVID? I think many of these has been covered by all my previous speakers. Vaccine breakthrough infections has already discussed. Reinfections are very common. How often, how common? Is it the same variant? After Covaxin, how many infections? After Covishield, how many infections? How many new infections you are seeing? The mucormycosis, is it only the immunity level? Is it only the steroid doses? Is it only the blood sugar level or something else? Is it the high doses of antibiotics we are using? How often we have to go for your CRP, ferritin, LDH, D-dimer, IL-6 antibodies? It all is a tailor-made for each and every patient. Don't go and jump for antibody test interpretation. If your antibodies are negative, don't feel that your vaccine is not effective. You may having T-cell immunity. How often you should go for a repeat PCR? Many of the employment authorities are asking for a negative RT-PCR. Sometimes you see get a positive RT-PCR even for 3 months also. Role of telemedicine has been increased enormously in this 1.5 years, but still we should be very judicious in interpreting the reports and giving the treatment. This is the standard protocol for the post-COVID and the long COVID. Those who are interested can take this. But my carry-home message for all these things is every patient is a different person. You have to assess him differently. Don't go on writing the battery of investigations. Don't go on writing a stereotype prescriptions. See the patient, understand the patient, Rather than your treatment, the patient is more in need of empathy from the doctors. And every visit, you have to see the subjective assessment of the patient. If you are unable to do, you can go for a teamwork like an educator in your clinics, you can go for. Pulmonary rehabilitation is very, very important. And all these things, even after you take vaccine, even after you get infection, even after you have suffered from severe COVID, the only things you are supposed to do is again mask, hand wash, physical distancing, early detection of complications. In the data studied from the doctor's mortality, because I am also the part of the death audit expert committee of the Chittoor district, what we have understood is late presentation of the doctors to the hospitals, because they treat themselves. They don't accept that they are getting the complications. They don't share their complications to many of the doctor colleagues, and early effective treatments has to be taken. And most of the time we doctors, we think of all uncommon complications because we behave like a patient, but optimistic attitude for a COVID-19 patient is more important rather than all these drugs. So I think we, myself and Dr. Mukherjee has shared many of the TV screens. We know what exactly is happening. False evidence is appearing real because those who speak loud, they are giving this false evidence. But as a physician practicing for more than 2 decades, I realized that we have to face everything. We have seen so many pandemics, so many epidemics. This is a new pandemic, and all the complications in post-COVID-19 can be faced with the optimistic attitude, and we have to recognize the complications early, and we have to get the best possible treatment from our colleagues, and need to have the multidisciplinary management. I pay my tributes to all the doctors who lost their lives in the COVID pandemics and to all the healthcare workers. As per Dr. K.K. Agarwal sir words, our show must go on. Even I am a patient, my family members are patient. If I lose my family members, my job of being a doctor has to be done, and we all are doing this. Thank you very much. I thank Dr. Subramaniam sir. I thank Dr. Vani for being with me in these tough times of doing this webinar. Thank you very much for your patient hearing.
Thank you, Dr. Krishna Prasanthi. Really a wonderful presentation. ఇంకా గుక్క తిప్పుకోకుండా చెప్పడం అంటారు కదా, అదే బ్రహ్మాండంగా చెప్పాను. I really appreciate, because the time is short. In the given limited time of 15 to 20 minutes, you have covered so extensively, and also you have emphasized the need of lab reports which are to be done repeatedly. Everybody need not run for repeat RT-PCRs and all. You have emphasized very critically, and I really appreciate Dr. Krishna Prasanthi. Please stay back. I now invite Dr. P.V. Sudhakar. It is my proud privilege to introduce the next speaker, Dr. P.V. Sudhakar. It is my privilege because he happened to be my teacher during my MS period, and he is my mentor. I have been imbibing and observing him keenly to develop some of the good qualities. And he is presently the professor and heading the Department of Plastic Surgery, Andhra Medical College, and he's also the principal and dean Andhra Medical College. He was the former superintendent of King George Hospital, and he is connected to this by also another special means, because he is a COVID special officer for all the districts here. And incidentally, he is a true academician. He is the chairman of Board of Studies of Dr. NTR University of Health Sciences. He is a member specialist board of the National Board of Examinations, and the main thing is he is an alma mater. He is an old student of Andhra Medical College, and did his MS, MCH, and also DNB plastic surgery from the prestigious postgraduate institute of medical education. This is PJ Chandigarh. He has won several awards. If I start telling, the session will go on. So he is the best outstanding. Received best outstanding services from the district collector for more than 8 times, and he received best teacher award from Dr. Y.S. Rajsekhar Reddy, the former Chief Minister of Andhra Pradesh. With this, I now introduce Dr. P.V. Sudhakar. Sir, please. He'll be talking about the third wave, the recap and way forward.
Yeah, thank you very much, Shekhar, for that wonderful introduction. Am I audible to all of you?
Yes, sir. Clear. Your slides also seen.
Yeah. Thank you very much, Shekhar, for that generous introduction. And as a last speaker, I carry the baton to complete the race. And before that, I wish to thank my dear friend, Dr. Srihari, and I wish to thank Dr. Krishna Prasanthi, Dr. Aivani, and the entire executive of IMA AP State, as well as the national executive. And as we have seen throughout the day, and as it has been started with Dr. PJ Srinivas about the first and the second waves, I shall be taking a little recap as to what has been done and how we are progressing. Whatever I tell you now will be mostly from the experience that we have gained in the district of Visakhapatnam, where we are part of the strategy management, and this basically can be extrapolated to the vision of the state of Andhra Pradesh, because whatever is the desire or the vision of the experts in Andhra Pradesh is basically will be dealt with by in the various districts, and I'm glad I'm the part of that. As you're all aware that we learn a lot from the past. As Judge Shantayana said, those who cannot remember the past are condemned to repeat it. So the first and the second wave of COVID have taught us a lot of lessons. So we go forward looking at the basics that we have learned, as well as the mistakes that we have made and how to overcome those mistakes. If you go through the analysis, if you see the Worldometer today, and if you see that India stands second only to USA in the number of positive cases that we have, and to the tune of 2.9 crores, and it's a close second to the United States. But if you look at the total number of cases per million, we are a little happy in the sense that we have only 21,000 per million, whereas it is almost 1 lakh for America. But on the contrary, if you see the number of tests that we have done compared to the America, about 14% of the American population had their tests done for COVID, but we have only 2.7% of our population have been tested. So this comparison is rather important because we as a nation with the huge population have a lot more challenges compared to what the other worlds have. That's the reason why we have to learn from others' experiences, as well as we have to learn from our own experience. So if you see the statistics in India, if you see the number of active cases, this is very popular as to how it has increased over a period of time and how they are declining now. Similarly, the number of cases that have been closed and the deaths that have occurred. And if you see the daily new cases, you can see what the wave pattern, the first and the second waves. And fortunately, the second wave is also coming to touch the baseline over a period of time. This is what is the first wave, and the second wave we have reached the peak, and it is much greater in its proportion compared to the first wave. And fortunately, now it is trying to touch the base, and soon I'm sure that we are going to have the good days. And similarly, the deaths also have increased enormously compared to what we have seen in the first wave. And so that actually taught us many more lessons. So taking the Visakhapatnam, I have just tried to put the numbers that we have seen in Visakhapatnam, which largely depicts the numbers that we have in the state. If you see the months of March and April, see the exponential rise in the number of the active cases, and at the same time, the number of deaths that we had over a period of time between the in this March and April. But still further, if you go, you can see the number of cases that we had in the month of May, and which are trying to come down, and similarly the deaths in the month of May. So this basically indicates that we had the first wave, we had a more severe second wave, and we are towards the closure of the second wave, and when we have to be much more careful when we are dealing with the third wave, which is which we can get. Why do we get the third wave in the first place? Basically, there are three factors which are responsible for having these wave patterns. So whenever we call it as a wave, we have more number of cases in a fixed time frame. So one is the agent factors, like we have the mutant virus, which tries to show up and tries to establish itself. The second one is many of the behavior of the human beings not following the COVID appropriate behavior adequately. And the third one is such as certain environmental factors like lifting of the lockdowns and all, because we cannot be permanently in the lockdown. So these are the factors which basically contribute for having these different waves of the disease when we have a large number of the patients in short span of time. And presently, as we see, the positivity rate is around 5% or a little less than that. And by 20th, we have our strategy is to see that it comes down to to less than 1%. The basic strategy of the government of Andhra Pradesh has been, as you all know, testing, tracing, and treating. So you test as many as possible, but the test should be very focused, and we have to trace all those people who have been tested positive and their surroundings, including the people whom they come in contact with, and treat these patients effectively in order to reduce the death rate. So our strategy has been and will be this particular testing, tracing, and treating, which has not changed from the first wave onwards. So now in the third wave, or the wave that needs to come, we are all planning, the government is planning to have a village or the ward secretariat as the nucleus. As you're all aware, that ward secretariats have been developed over a period of time after this government took over, and that is to give a wholesome care to the people in the surrounding the secretariats. So, like I have told you, we have to reduce the positivity rate by focused testing in the form of we trace all those symptomatic patients who are the primary contacts of the positives. That's where you find a lot of positives. The second one is the government has taken a beautiful initiative of having repeated fever surveys in the different wards at the ward level. So you take all the symptomatics with fever and test them so that you can find certain positives and isolate them early on so that the transmission chain can be broken. And the third one is you test all the symptomatic contacts of those people who have died over the last 14 days. That also gives us a chance to test in a very focused way. And lastly, all those people who wish to be tested, they make calls to the 104 call center, and they need to be tested because their concern has to be addressed. Unless they have some symptoms, people will not come forward to test themselves, to get tested themselves. That's the reason why. So these are the four important groups that we need to test in order to break the chain of transmission. So this is the primary idea of the government to improve the testing as well as tracing the individuals. Thereby we can treat appropriately in order to get rid of this particular wave. So where do we test is another important question. Till recently, we have been testing more so in urban areas, and we have been testing in the private laboratories. But government has realized that it needs to be decentralized. The testing needs to be decentralized to the level of, we have to go to the level of subcenters and the PHCs. People should be tested there and then itself so that it can be better handled. So the place of testing in the newer strategy would be the subcenters and the PHCs, and the nucleus is this ward secretariat. There are different modes of testing, as we are all aware. So the rapid antigen test has been utilized for testing the rural and the agency areas more, and also to the 104 request for two reasons. In the rural and agency area, for getting the samples to the main laboratory will be enormously delayed. Meanwhile, we will be losing valuable time in identifying the positives. That's the reason why the rural and agency areas, the testing should be fast enough. And similarly, the persons who would be requesting for testing should be tested by the rapid test, because we have to give them the results early on so that they will be knowing whether they are positive or not. Similarly, in the urban area and all those where the rapid test is negative, but people are symptomatic, RT-PCR is used as the modality of testing. And with this, in the urban area, it's easy to get the samples. And at the same time, all those who are symptomatic negatives on rapid antigens, if they are tested RT-PCR, they can be sure whether they are positive or negative. And the government has also taken a lot of initiatives for expeditious movement of the samples in VRDL and to see that there is no backlog in the laboratories. And the aim has been to declare the results within 24 hours. As you're all aware, during the second wave, there was some concern about not getting the results on time, so that a positive individual, after giving a sample, would be mixing up with the other individuals, causing a lot of transmission. So this has to be broken at any point of time. So that's the reason why the declaration of results is being concentrated very well by the government. And after declaring the positive, the follow-up of these individuals is very important. Like I have told you, through the village and ward secretariat mechanism, every individual positive has to be identified and their primary contacts have to be noted down and they need to be followed. That's the strategy. And home isolation has to be enforced very strictly, and there should be frequent visits by the ASHA, daily visits by the ANM, ASHA, the medical officer, to ensure that these positives will not come out to the society and infect more number of people. And similarly, by daily visits, the follow-up of the asymptomatic primary contacts can be seen. Once they become symptomatic, they will be tested so that the chain of events can be broken. So, and the state government has taken another initiative of home isolation of isolation, as well as distribution of the kits which are necessary for their treatment at home. As we know that 90% of the individuals do not require hospitalization, so they need to be followed rigorously in order to have a better milieu in the society. And village isolation centers have been created at the rural and the tribal areas because it's difficult for them to be at homes. Most of the people will have single room houses in the villages and the rural areas. And these centers are manned by the ANM and the Mahila police so that people are isolated well and they will not come into the public. So in urban and semi-urban areas, COVID care centers have been established in large numbers by the government so that people who do not have adequate facilities at home will be kept in these COVID care centers, which are again manned by the doctors, qualified doctors and nurses. If there are any deterioration or if somebody becomes symptomatic, can be shifted to the hospitals. And running fever clinics and identifying symptomatics is another great initiative because already 10 rounds of fever clinics have been, fever surveys have been done, and fever clinics have been established in all these wards to see if somebody has the fever, they should immediately be tested. Intensive testing is done in the containment zones, particularly when you have the large conglomeration of the positive patients. And one has to understand that state government is taking the vaccination drive also very effectively, hand in hand with the strategy that we have been following of testing, tracing, and treating. And because of the dearth of vaccines, it's only the 45 plus, and earlier we had 60 plus, and after that it is 45 plus with comorbidities, and later it was 45 plus category that is being vaccinated. And in the state of Andhra Pradesh, the 45 plus vaccination would be completed by 20th of this month, involving again the village and ward secretariats at all functionaries, so that they'll be identifying people who are above 45 in their particular wards. So this is the decentralization that is being done, so that we get 100% of vaccination in 45 plus for whatever vaccine that is available for us now. And now we have taken another initiative in the form of all mothers with children aged between 0 and 5 are to be vaccinated. So this is also being done expeditiously, particularly through the village and ward secretariat identification. So students who are working, students who have to go abroad, or those who are working abroad and want to go abroad will get a preferential vaccination done. So in future, we all have to look forward for 18 plus category vaccination, pregnant and lactating women vaccination, and pediatric population vaccination. But all this depends on the availability of the vaccination from the government of India. coming to the treatment protocols and the treatment initiatives that are taken by the government of Andhra Pradesh are, so particularly when it comes to the third wave, we all have to gear up to have more number of cases, expect more number of cases that are going to come in next couple of months. And the government has taken a newer look at this, a newer strategy at the policy that is being adapted is strengthening of the secondary level of healthcare facilities. Like earlier in the first and the second phases, there was a lot of pressure on the tertiary care centers and everybody has to come from far off places. So instead of that, if the secondary level of healthcare facilities are augmented, if they are strengthened, perhaps the load on the urban area and the load on the tertiary care centers can be minimized. And accordingly, the 20-bed facility at all the CHCs and area hospitals has been envisaged and with oxygen facility. So now that we have a month's time before we can actually expect a rise in the cases, we all are gearing up to increase the oxygen facility to the beds that are going to be created at the peripheral level at the CHCs and area hospitals. And similarly, the government is also contemplating on positioning trained doctors in these facilities so that the patients need not come to the cities and to the tertiary care centers, which can be managed at the CHCs and AHs. So by placing one internal medicine specialist or a pulmonologist at these centers, which handles at least 20 beds, the number of cases that come to the urban area or the tertiary care centers can be minimized. And simultaneously, during this month, a lot of training is required for the doctors and the paramedics in order to have an effective treatment protocols. Everybody should know what the treatment protocols are and what each one of us are talking about through various webinars and short-term clinical attachment to the tertiary care hospital so that they can go back and give the treatment to the individuals at the secondary level of healthcare facilities. So requisite oxygen supplies, oxygen concentrators, medical equipment and medicine will be made available at the secondary level of healthcare facilities, and ambulances will be positioned during this third wave at the secondary level of healthcare facilities for quick referral to the tertiary care centers by giving them the reasons for the real situations wherein individuals have to refer the cases. So the strengthening of the district hospitals have to be done on par with the teaching hospitals. Now every district has got at least 2 district hospitals. They are to be enhanced with, they have about 200 beds in them. So they are to be made good hospitals with the facilities that a tertiary hospital has, so that the burden on the tertiary hospitals can be minimized. Similarly, on one hand, we are strengthening the secondary level of healthcare facilities. On the other hand, we have to take care of the tertiary care services also. And broadly, the guideline would be that we may have at least 50% more cases than we had in the second wave. That is the estimate. So the facilities also have to be enhanced by at least 50% for the third wave. So these are all the guidelines that the government is giving, and this is the vision of the government of Andhra Pradesh to go and in order to face the third wave. And a word about caring of the pediatric population. A lot of discussion is going on the pediatric population that's going to be infected in the third wave. The main reasons that are usually seen for this particular speculation would be, number one, the pediatric age group has not been vaccinated, number one. Number two, the schools are to be reopened, and when the schools are reopened, even if one child gets infected, it's very difficult to enforce the COVID appropriate behavior amongst the children, and there will be a lot of gathering of children. So the more children would get affected. So there is every chance that more number of children will get affected in the third wave. So there are a lot of forecasts that are given by the epidemiologists, and accordingly, there is an expectation of that the government of Andhra Pradesh state will get about 18 lakhs of new cases, out of which about 4.5 lakhs would be the pediatric population. That's a huge number, as we all know. Of this, about 90% of them can be managed at home, maybe around 4 lakhs of the children. But there is a whopping hospital admissions would be required, about 8% of them, which would come to about 36,000 of hospital admissions. And we should get prepared for about 9,000 of ICU admissions amongst the children, which would be around 2% if you take the adult similarities with the adult population. So this is how the preparedness for the third wave is going on, looking back and taking the lessons that we have learned from the first and the second wave. And I wish to thank you all for your attention. And if there are any questions with regards to the policies or the strategies that the government of Andhra Pradesh is going ahead with, or in particular the district of Visakhapatnam or the North Coastal Andhra Pradesh, I'll be very glad to handle them. Thank you very much, Vijay Shekhar, and the host of the organizing team, who have done an excellent excellent session right from the beginning. Thank you very much.
Thank you, sir. Thank you, Dr. Sudhakar, sir. It is really informative, and all the doubts about which population, how they are going to be affected, how we should be prepared, you have nicely elaborated. Now, I think Dr. Mukherjee, you are there. I think all the speakers, Dr. Suresh, Dr. Mukherjee, Dr. Prasanthi, all are there.
Mukherjee sir is there, sir.
Okay. Dr. Mukherjee, there are many appreciations for your talk as usual, and some of the quotes you are mentioning, immunize against the misconceptions. That's really wonderful, because we need to immunize not only against the disease but also against the misconceptions, as you rightly told. And sir, you are talking about also the civil debates. You are rightly given a instantaneous and correct reply to the one chemical engineer who has made a debate in the TV. That was your reply to him was appreciated by one and all. So thank you very much for your active role in these parts. And there are few questions for you, Dr. Mukherjee. Dr. Mukherjee, are you there? Dr. Mukherjee?
I don't think he's there. I think you can give the questions to the next speaker.
Yeah, I'll take up the questions, no problem.
No, okay. Dr. Prashant, you can even tell. One of the questions raised by one of our colleague, Dr. Gayatri, is, suppose the healthcare workers have received 2 doses of Covishield, but their antibody levels are low. Will they be advised a booster dose by Covaxin? That is a doubt expressed by Dr. Gayatri.
Sir, right now, according to the Ministry of Health and Family Welfare, we are not supposed to do that. But already the trials have been started, whether there will be a robust immune response after giving this kind of booster doses. Until the official guidelines are there, we are not supposed to give that kind of vaccination. We are not supposed to promote that kind of booster dose to the healthcare workers.
Right. Thank you. And also one more question, as a physician and also having a lot of work in this COVID patient, I think you can answer this also, Dr. Prasanthi. Antibody-dependent enhancement of reinfection. Sir, actually, one of the Nobel laureate has also gave a talk, and which has got frightening remarks by all the healthcare workers. Your comments on this?
Sir, there is an actual message that those patients who have received 2 doses of vaccination will die in 2 years. That was really alarming and frightening to many of the healthcare professionals. Actually, it's not only the B-cell immunity and the amount of the antibodies that is getting protection, it is also the T-cell immunity. So by mere measurement of the antibodies, the extent of level of antibody protection is not going to know what exactly is happening. It's totally the immune dysregulatory mechanism which exactly is happening, and what we are having in the memory cells which is going to take care of it. I think in one of the recent publication in the Nature, I believe that those who got mild COVID positive may be having long-lasting infection for 1 year or up to lifetime. So each and every day we are getting a new information. As far as possible, we should not be getting panic with that kind of information. Those who have received 2 doses of vaccination or 1 dose of vaccination, either with Covaxin or Covishield, don't worry. And if you get any mild infection, accept it, go for early treatment. That itself is my message.
Thank you, Dr. Prasanthi for clarifying the concerns. I don't think I have been scrolling down all the.
I have seen, sir,
chat-
2 or
chat
3 questions
boxes.
are there. I have noted down.
Because many are appreciations to the speakers only. You can
No,
go
no,
to
sir.
the.
Two or three important questions. Role of steroids in long COVID and post-COVID. Actually, many of the practitioners, after giving this dexamethasone and methylprednisolone, they have given the oral supplementation. But I think according to the government of India guidelines, it's only for up to 10 days. When you are giving steroids for a period of 10 days, there is no need for tapering dose. But in the case of patients who need a long-term doses of steroids, prednisolone also can be given, but it's only for a period of 1 or 2 months. But those chronic pulmonary disease patients, those patients who are already on autoimmune diseases with steroid patients, they may continue their regular steroids. The next question could be, what could be the percentage of increased incidence of mucormycosis or secondary bacterial infections and diabetes? So when you are giving a drug, accept the complication. Meticulous monitoring is important, and you have to give the steroids. Because of fear of steroids, somebody are not taking the steroids and going for complications. The other question is the role of immunomodulators in the post-COVID. I think there are no regular immunomodulators. As on now, vitamin D has been lot of research is going on. It has been shown that daily dose of 60,000 IU for 5 days to 7 days has been studied in some of the ICUs, but vitamin D is also having toxicity. Without monitoring, without estimation, going on dumping with this kind of immunomodulators is also harmful. Then role of this zinc, vitamin C, everything is day in and day out is controversial. So there are no specific immunomodulators as on now. The other question is new onset obstructive lung disease. Will new onset obstructive lung disease occur after COVID with lung involvement? Yes, pulmonary fibrosis has been reported. There are few cases with 20 to 30% of the lung is getting fibrosed. There is a minimum role of the fibrolytic drugs, but pulmonary rehabilitation is important. It's only 1 to 1.5 year old disease we are seeing. We don't know how much it's going to be like an interstitial lung disease or idiopathic pulmonary fibrosis, because we see good number of rheumatoid arthritis patients taking methotrexate, again getting these ILD manifestations. Like this, when we have seen the HIV epidemic in 2000, where we have seen PCP pneumonias and pulmonary manifestations, this kind of new kind of pulmonary manifestations, we have to wait for another 1 to 2 years. Whether we can see a long-term obstructive pulmonary phenomena can be there. As on now, expected fibrotic lung disease can be there. Pulmonary rehabilitation is important. Then role of antifibrotics, again, it's still controversial. People have been trying. I think we need some more time to get the exact data on this pirfenidone drug. I think 4 questions are there, sir. I have answered, I think.
Okay, that really excellent CME, Dr. Krishna Prasanthi. I wholeheartedly congratulate the Academy of Medical Specialties IMA AP chapter, both Dr. Prasanthi and Dr. Vani, and also the state team led by Dr. N. Subramaniam Garu. I think now it is time to conclude. I have been observing in any given time there are more than 500.
Sir, we asked Dr. Subramaniam sir and Dr. Sriharas. Sir. I think Dr. Subramaniam sir can give the remarks, and Dr. Sriharas sir also.
And only one question, if there is Dr. Madhusudan Garu, sir is there?
Yes, sir. Sir is there. Sir is there.
I am there, sir.
Sir, good afternoon. I just have one question from my side. Sir, I am a neurosurgeon. We are having a good number of mucormycosis cases in our ward. KGH, we have more than 110 plus cases, and we have operated more than nearly 40 cases so far, of course, mainly by ENT surgeons. Sir, is there any role of local amphotericin injectable B topical after the debridement of the test? Because retroorbital, the ophthalmologists are saying. I wanted to know your experience and the scientific rationale, if any.
Yes, sir. It's a very good question, sir. We have just 2 days back, we have operated a 60-year-old teacher with severe extensive orbital this thing. After removing, we have taken gel foam, absorbable gel foam, sir. We have put in that debrided or removed cavity and we have soaked with amphotericin B. And I do not know how far it will acting, but we can put absorbable sponges soaked in amphotericin B, and it's an open cavity. If something is wrong, you can 2 days you can remove it. But inaccessible areas, putting amphotericin B soaked in some material, I do not have much experience. But for my nasal cavities, maxillary sinus, nothing to worry, sir. Intracranially, I do not know.
No, about ENT, sir, topical on intracranially,
Yes,
we
sir.
also do not have any.
But doesn't have, only you can keep the sponge soaked in amphotericin B and put it for 2 days, like 48 hours as a topical.
Right, sir. Thank you. Thank you for clarification.
This is Dr. Suresh regarding antipsychotics in COVID. Madam Krishna Prasanthi sir, Madam was commenting. The ideal antipsychotic to be used in psychosis along with COVID is quetiapine and lurasidone. Quetiapine is generally doesn't interact with other drugs because metabolism is different from C450 M9. So quetiapine is preferred up to 100 mg in old people, up to 300 mg in young adults we can give, madam. And lurasidone is also another newer antipsychotic which we can give in COVID patients compared to the older antipsychotics. Thank you.
Thank you very much, sir. I think 2 more questions are there, sir. Vijay Shekhar, sir, can I take that? When to vaccinate postnatal mothers? Now the latest Government of India guideline says that immediately after delivery they can take whichever vaccine they want to choose. The other thing is the cocktail antibodies. Recently they have came that has to be given in very early mild positive cases where you can have a rapid antibody response. Now it has been started in the hospitals. We don't have a long-term data in our place, but still patients started using this. But once the patient is having comorbidities, if the patient is having raised inflammatory markers, if the patient is having pulmonary manifestations, I think they may not be suitable for that kind of patients. Sir, Subramaniam sir, మాట్లాడతారా sir?
Krishna Prasanthi garu. So may I now request the IMA President AP State, Dr. Subramaniam sir, to please give the concluding remarks, sir.
103 ki beta.
It's a very nice webinar.
Dr. Madhu, can you mute? Dr. Madhu, can you mute?
I'm very happy this nice webinar. It's a very good webinar, and all the speakers have done justice to their respective topics. And I'm sure most of the attendees are enriched with lots of knowledge in relation to the COVID, and so many doubts are clarified, and so many COVID-related issues were discussed in detail. And I'm extremely thankful to all the speakers who have participated today on a Sunday. And I once again thank the Chairman Krishna Prasanthi and Secretary Vani and the other members who have taken up this issue of conducting the webinar. And it is, I feel it's a successful one. I once again request all the participants here to become the members of the AMS, and then get the, just it's a simple process, fill up the application form and send a very nominal 1,000 rupees, send it to the IMA state office, you'll become the members of this thing. And also the agitation against the assaults on doctors on 15th and 18th, please participate and let us, it is not a protest, it is just to express our resentment to the public about the assault on this thing, and to bring it to the notice of the public, awareness among the public, the increasing incidents of the assaults on the doctors, and that too who are engaged in this very difficult task of the COVID treatment. So that part of it we will take up 18th and 15th. All of you please participate, and thank you very much. Thank you for giving this opportunity.
May I now request Srihar Rao, sir?
Good evening, madam. It is an excellent program. It is a memorable webinar. It is useful to all the people from the PhD to the tertiary care. Almost contemporary issues are discussed regarding COVID. It is very useful. I convey my congratulations and appreciation to the IMA, AP State AMS team and other speakers. Happy to Dr. Sudhakar, see you, Sudhakar sir, after a long time, and other friends in the webinar. Thank you. I once again congratulate the team IMAMS and IMA AP State under the leadership of Dr. Subramanian sir and Dr. Nanda Kishore. Thank you. Thank you.
Sir, Sudhakar sir, your comments on this webinar, sir?
Yeah. Thank you very much, Vani, for asking me to speak. I mean, I think at the end of the program, I felt that probably this should be the way it has to be conducted, because everybody stuck to their time, everybody stuck to their subject without much deviation from the main what they're expected to speak, and covering so many topics in such little time is something which is unprecedented. And if you see the participants, there are more than 500 participants almost till the end, which again indicates perhaps this is the only forum where we have given our lecture for such a big audience, which we never had it before. Sometimes it appears to me that probably this is better than our physical conferences. It makes you tied down to your chair and you tend to listen very intently, otherwise you will be missing some point. So hearty congratulations both of you, Krishna Prasanthi and you, for a wonderful job that you have done. I have a small query. You know, I have become an AMS member about 25 years ago. Would my membership still is continuing, or is there any data that whether my membership is there or not, or do I have to take the membership again? So I've been a member in 1997 itself. I really do not know whether I continue to be a member. Please look into the records and see if I am still there.
Dr. Sudhakar, congratulations. You have done a very good job in your talk, and your membership will continue. And because I was a member of the AMS in 1991, so still my name is there in the list. I am sure your name will be there in the list.
Same doubt with me, sir. I just want to know.
And you please, Dr. Sudhakar, you please help us in enrolling more number of all our members, because you are dealing with all postgraduate teachers and postgraduate students and all that. They are all eligible to become the members of AMS. Please help us in enrolling more number of these things.
Yeah, we'll have a drive, sir. We'll have a drive, and the next 15 days we'll complete that.
Thank you. Thank you very much. Thank you very much.
Madam, Dr. Bhavani Prasad, Vice Chairman.
Yes, Bhavani.
Dr. Bhavani Prasad, sir?
He is the Vice Chairman of IMA AMS. Sir, please your comments, sir.
Good afternoon, all of you. Madam, today the program is very good, madam. Thanks for conducting such a nice program. And we all enjoyed the program, madam. Since morning, I am on line hearing to all this thing. It's very good one, madam. I think you can organize one more soon, madam. Congratulate you, madam. Thank you.
Sir, Dr. Prasad Reddy, sir, unnattunnaru. Sir, Prasad Reddy, sir.
Dr. Prasad Reddy, sir. SVK Prasad Reddy, sir.
So, thank you. Webinar was very excellent, madam. Speakers anta chaala baga chepparu. Em problem le. Mukherjee sir okkaru koddiga speed అయిపోయింది. అదొక్కటి. మీ అంతా మీ స్లో ఉంది, బట్ వెరీ ఇన్ఫర్మేటివ్. చాలా బాగుంది. సో ఫుల్ మార్క్స్ 2 క్రెడిట్ అవర్స్ పార్టిసిపెంట్స్ కి ఫుల్ మార్క్స్ ఉన్నట్లే. 2 క్రెడిట్ చాలా ఇది రియల్లీ 540 and odd. So we'll give all credit points to all participants. Thank you on behalf of
Prasad Reddy sir. Thank you, sir. Short notice lo credit hours ippincharu. Thank you very much. And అందరూ ఉన్నారు సార్, ఇవాళ అందరూ స్టిక్కర్ అయి ఉన్నారు సార్.
రూల్స్ కి అగైనెస్ట్ కదా, 1 month బిఫోర్ అప్లై చేయాలి కదా విజయశేఖర్.
లేదు సార్, అప్లై చేస్తారు సార్. డీడీ తీయడం లేట్ అయింది సార్.
అదే అంతే గురించి నో ప్రాబ్లం లేండి, బికాజ్ ఇట్ ఈస్ AMS
మేడం మెంబర్షిప్ రిగార్డింగ్ మెంబర్షిప్ 344 మెంబర్స్ ఉన్నారు మన స్టేట్ నుండి.
అవునవును.
టోటల్ అవుట్ ఆఫ్ 16,000 ఇన్ నేషనల్ వైడ్ గా 344 మెంబర్స్ ఉన్నారు. కాబట్టి సుధాకర్ సార్ అయితే సుబ్రహ్మణ్య సార్ ఆల్రెడీ ఉన్నారు కాబట్టి డెఫినెట్ గా సుధాకర్ సార్ ఉంటారు. కాబట్టి ఇంకా మోటివేట్ చేద్దాం మనం. మినిమల్ కాంట్రిబ్యూషన్ కాబట్టి మనం డెఫినెట్ గా యాక్టివేట్ చేసి మన మెంబర్షిప్ ఎన్హాన్స్ చేద్దాం ఫస్ట్.
Srihari, we will do that.
Thank you.
So on the behalf of the Academy of Medical Specialties, IMA Wing AP chapter, I'd like to propose a vote of thanks. So ever since we have conceived the idea of doing the CME on May 22nd, so it was only 20 days. So such a fruitful CME. So thanks to Dr. Krishna Prasanthi, and also thanks to Dr. Subramanian sir, so for your wholehearted support. And special thanks to SVK Prasad Reddy Garu for obtaining the credit hours for us. And also thanks to the APMC observer, Dr. Subba Reddy Garu, so for observing all the events. And then we all promised that for all the participants who have logged in from morning to 2 o'clock, they'll be receiving the certificates very soon. So thank you very much, everyone. Thank you all for the support and encouragement. I thank all the speakers, like what Subramaniam sir and Sudhakar sir were saying. All were sticking on to their domain, and it was really excellent. And in the chat box, we can see so many appreciation for all the speakers. And on the proud thing is that it started at 9 sharp and it ended at 2 sharp. So it was a 5-hour CME. So thank you very much, all the participants and all our seniors who have encouraged us to do. Thank you very much.
Thank you, sir. So nice of you.
Thank you.
So we'll dissolve the meeting.
Yes, ma'am. Yes, ma'am. Thank you, sir. Subramaniam sir, Prasad Reddy sir, Srihar sir, Sudhakar sir. Suresh sir, very nice sir. మీరు ఒక 2 hours పెట్టుకోవాలి సార్ ఎప్పుడన్నా ఎక్స్క్లూజివ్ గా క్రెడిట్ అవర్స్ తో సంబంధం లేకుండా ఒక్కొక్క స్పీకర్ కి 2 గంటలు ఇచ్చి డిస్కషన్ పెట్టాలి సార్.
Thank you very much. You have conducted excellently, madam. 500 is a world record. I think these days of webinar mania, daily 5 to 6, 500 people attending is a record, really. And keeping on them till 2 p.m. is really record.
Correct.
Record.
మా వెంకటేశ్వర స్వామి దయ సార్.
మీది మాత్రం చాలా బాగుంది సార్. యాక్చువల్ గా నేను కొన్ని ఉన్నాయి మీతో ప్రస్తుతం మాట్లాడుతున్నాను. ఎందుకంటే ఈ హెల్త్ కేర్ ప్రొఫెషనల్స్ మీద ఒకటి ఉన్నాయి సార్. పేషెంట్స్ కూడా చాలా అబ్జర్వ్ చేసాం సార్. మాకు ఇక్కడ ఫెసిలిటీలోని ఈ కోవిడ్ కేర్ ఇది ఉంటే పైనుంచి జంప్ చేసి ఐసీయూ నుంచి సమ్ డెత్. అండ్ ఇది ఈ న్యూస్ విని అసలు దీనికి రిలేటెడ్ కాదు విమ్స్, మాకు కేజీహెచ్ వేరే ఏరియా, టోటల్ గా విమ్స్ నుంచి అక్కడి నుంచి కూడా ఇది స్టార్ట్ చేస్తారు. ఒకటి పడిపోతే ఇంకో 2 రోజులు మళ్ళీ ఇంకొకడు. వీ హ్యావ్ గాట్ అంటే ఇవి ఆఫ్ ద రికార్డ్స్. మనకంటే వాట్ ఆర్ ద ఆస్పెక్ట్స్ ఆఫ్ సైకలాజికల్ ఆస్పెక్ట్స్ పేషెంట్స్ డిప్రెషన్ అండ్ ఆల్. రెండోది ఏంటంటే సార్, ఇప్పుడు ఒరిజినల్ గా కోవిడ్ వచ్చి తగ్గడం వేరు, మియోకార్ వచ్చింది సార్. ఐ డోంట్ థింక్ ఇఫ్ ఐఎమ్ ఎక్స్టెండింగ్ ద టైమ్ దోస్ హూ కెన్ వాంట్ టు లీవ్ కెన్ లీవ్. మియోకార్ వచ్చిన తర్వాత పోస్ట్ కోవిడ్ అది ఇంకొక డిప్రెషన్ సార్. And if it is extending into orbit, removing the exenteration is much more having depressive effect, sir. So ivanni kuda psychological chain of events chala unnai sir. Probably we need to discuss at a later date. As madam was telling, we can have individual sessions, sir.
అవును సార్, ఒక 1 hour 2 hours ది పెట్టుకుందాం సార్. ఇందాక అల్లాడి మోహన్ సార్ ఫోన్ చేశారు సార్, స్విమ్స్ లో ఎవరో సూసైడ్ చేసుకున్నారంటే ఒక సిస్టర్.
అదే మేడం నేను చెప్తున్నా.
ఇప్పుడు అందుకనే సార్ వెళ్ళిపోయారు. ముఖర్జీ సార్ మెసేజ్ పెట్టారు, హాస్పిటల్ కి అర్జెంట్ గా వెళ్తున్నానని. మాకు కూడా మా కలెక్టర్ భరత్ గుప్తా గారు ఉన్నప్పుడు మమ్మల్ని అడిగేవాళ్ళు, ఎందుకు కోవిడ్ లో ప్రత్యేకంగా పైనుంచి కిందకు దూకుతున్నారు, దీనికి ఏమన్నా స్పెసిఫిక్ గా కోవిడ్ పెథోఫిజియాలజీ ఏమన్నా ఉందా చూడండి అన్నారు సార్. ఎక్స్క్లూజివ్ గా ఈ డిసీజ్ లో ప్రాబబ్లీ ఈజీ యాక్సెస్ వే అనుకుంటున్నారో ఏమో తెలియదు సార్. తిరుపతిలో కూడా చాలా జరుగుతున్నాయి సార్, సగం బయటికి రావట్లేదు.
Definitely, madam.
Sare madam, anyhow, wonderful sessions. We can have small meetings frequently.
అది చేద్దాం సార్. once in 15 days స్మాల్ మీటింగ్స్ పెట్టుకుందాం సార్.
మేడం ఇవన్నీ కూడా AMS ఏజెస్ తో చేయండి మేడం. ఏముంది, ఎవ్రీ వీక్ ఏదో టైంలో పెట్టుకుంటే జస్ట్ 1 hour 1.5 hour Right, madam. Thank you very much.
Suresh Garu is the chairman of the CGP. So he can also conduct some meetings under the CGP also. వెళ్ళిపోయారా?
సుబ్రహ్మణ్యం సార్, ఉదయం నా దాంట్లో చెప్పాను సిజిపి తరఫున ఒకటి కండక్ట్ చేస్తే బాగుండేది.
అవును, అదే
చెప్పాలి.
నేను చెప్తున్నాను, నేను లాస్ట్ నవంబర్ డిసెంబర్ నుంచి వీళ్ళ ఏఎంఎస్ సిజిపి ఇద్దరిని కూడా కంటిన్యూస్ పుష్ చేస్తూనే ఉన్నాం. బట్ నౌ ఏఎంఎస్ వాళ్ళు బట్ అఫ్ కోర్స్ మనకి కోవిడ్ ఒకటి కొద్దిగా అట్టగా వచ్చింది కదా, అందువల్ల కూడా డిఫికల్ట్ అయింది. బట్ ఏఎంఎస్ పీపుల్ ఒక్కసారి బాగా బ్లాక్ బస్టర్ మూవీ లాగా బాగానే ఫస్ట్ సిఎంఏ బాగా చేశారు. అయితే ఐ ఎక్స్పెక్ట్ సిజిపి ఆల్సో ద సేమ్ థింగ్ విచ్ విల్ బి యూస్ఫుల్. ఆల్టర్నేటివ్ గా ఇద్దరు చేస్తూ ఉంటే బాగుంటుంది.
అవును సార్, 1 month అట్లా 1 month ఇట్లా చేస్తాం.
థ్యాంక్ యూ.
నెక్స్ట్ మంత్ ప్లాన్ చేసి మేలు.
Also at the end, I would like to thank the Clarinet people for the good technical support. Without any technical hitches, the whole 5 hours went very, very smoothly. So thank to all the Clarinet people, Ishika and Arpita.
They are always obliging us, IMA AP State, and all these meetings, either the women doctors meeting or the previous intellectual meet, everything the Clarinet people are readily accepting it in a short notice. They are organizing things, taking all care to give it this. Thank you, Arpita and other members of Clarinet. Thank you very much. We will conclude this meeting. Thank you.